Oh, God. Good morning, Chairman.
Good morning. Before I move into my introductions, I would like to hand over to Trina Cope, please, to confirm the attendance of committee members.
Thank you, Chairman. Good morning, members. So prior to the start of the agenda, can I please ask members to confirm your presence when your name is called? Councillor Suzanne Barker-Milan.
Present.
Thank you. Councillor Bill Bilton.
Present.
Thank you. Councillor Chris Brewis.
Present.
Councillor Matthew Fido.
Present.
Councillor Mrs. Sandra Harrison.
Present.
Thank you. Councillor Mrs. Rosemary Cabley Brown. Not yet. Councillor Carl Macy.
Present.
Councillor Robin Renshaw.
Present.
Thank you. Councillor Angela White.
Present.
Councillor Mark Whittington.
Present.
Councillor Stephen Woodliffe. Councillor Stephen Woodliffe. Councillor Ray Wotton.
Present.
Dr. Brian Wookey.
Present.
Thank you.
Okay. In which case, I'd like to move.
Woodliffe here. Can you hear me?
We can, yes.
Right. Okay. Thank you.
Okay. In which case, I'd like to move into my introductions. Before continuing, I would like to welcome everyone who is in this appointment and listening online to this meeting of the Health Scrutiny Committee. We have already confirmed which committee members are present. We also have present Councillor Mike Thompson, Executive Support Councillor for NHS Liaison and Community Engagement, and Dr. Cowley Chowdhury, Public Health Consultant for Lincolnshire County Council. Other participants will be introduced when we reach their item. I would like to ask members of the committee and other participants to type "speak" in the chat function when you wish to ask a question or make a contribution. Also, please turn off your camera and microphone when not participating. And if you find issues with the bandwidth, please try just audio with the exception of voting. There is now a change in the voting arrangements, as it is now possible for laptop users to see up to 49 people on the screen. There is no need for any roll call voting as previously. When we conclude an item requiring a vote, I will ask all committee members to turn on the camera and all others present to turn the camera off. We can then use a show of hands so that it is visible on camera. I stress this is your own hand and not the buttons on the Teams. Please keep your questions and contributions succinct and concise, ideally no more than 2 questions per item. And I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive here. I'd now like to move to agenda item 1, apologies for absence and replacement members. Trina, please.
Thank you, Chairman. Apologies for absence have been received from Councillors Rob Kendrick, Colin Matthews and Glynis Scalesi. We have also received an apology for absence from Councillor Sue Woolley, Executive Councillor for NHS Liaison and Community Engagement. Thank you, Chairman.
Thank you. In which case, I'd like to move to agenda item 2, declarations of members' interest, please. Do members have any interest to declare?
Yes, Chairman, please.
Councillor Harrison?
Regarding item 7, as a patient of Connect Health, I have a personal interest.
Okay, thank you for that. If any other interests do come up throughout the meeting, please just raise at the time if you notice. In which case, we'll move into agenda item 3, the minutes from the 16th of September, which is page 5 to 15 of the agenda pack. This is to confirm the minutes held at that date. Can I ask a proposer for these, please, as I plan on taking them on block?
I'm happy to propose those, Chairman, as a fair record of the meeting.
Thank you, Councillor Brewis. Do I have a seconder, please?
Yes, happy to second that, Chairman.
Thank you, Councillor Wotton. Could I ask all members of the committee to please turn on those cameras, and those in favour, please raise your hand. Thank you, Trina. That seems...
Yeah,
that
yes, thank you, Chairman.
Thank you. That's unanimous. In which case, we'll move on to agenda item 4, the Chairman's announcements. My announcements have been circulated with the agenda, and there are supplementary announcements on 3 items. I propose to note the Chairman's announcements and supplementary announcements, which does not require a vote. Is there any dissent, please? No, in which case...
Only one thing, Chairman, which is thank you for their relevance and the fact that they come to us and they're all useful information for us. And thanking you very much for it.
Thank you, Councillor Brewis. In which case, we'll take that as noted. Thank you. In which case, I'd now like to move on to agenda item 5, United Lincolnshire Hospital Trust, first quarterly review of the Grantham site. This is pages 21 to 81 of the agenda pack. And just to confirm that on the 6th of October, the Board of ULHT approved the recommendations on page 57 to 58 of our agenda pack. I'd now like to welcome our presenters, Mark Brassington, Director of Improvement and Integration and Deputy Chief Executive for United Lincolnshire Hospital Trust, and Simon Evans, Chief Operating Officers for United Lincolnshire Hospital Trust. I'd like to hand over to you now for the presentation, please. If you can try and keep it to around about 15 minutes, and we'll take questions at the end. Thank you.
Okay, thank you very much, Chairman, and thank you for the invitation and the opportunity for us to talk through with you and to provide an update with regards to the Green Hospital site at Grantham. I'll provide a general update, and then I will ask Simon if he has anything he wishes to add, and at the end of that update, then open to questions. As you said, there's quite an extensive paper that we've shared with yourselves as part of your packs, which I'm not proposing to go through in a huge amount of detail, but I will pull out just some pertinent points. Just to remind people that the board considered at an extraordinary trust board on the 11th of June, as a response to the national level 4 COVID incident, we reviewed the option of creating a green site in order to restore public confidence in accessing healthcare. And we did actually approve that suggestion at that trust board on the 11th of June. The aim of that also, as well as restoring public confidence, was to reduce the risks for patients who are accessing routine surgery, because the evidence does suggest that outcomes can be affected for patients if they do contract COVID post-operatively. We also wish to protect our staff for their well-being, but also we needed to protect our staff because we needed them to be available to help provide the services for our population across Lincolnshire. And by doing so, we would make our services more resilient. Now, to do this relied upon a range of measures that we needed to put in place, and we put a large expectation upon our patients to be compliant with a range of measures, and also upon our staff, so we could reduce the risk of a patient or a staff member bringing COVID onto our hospital site, and particularly onto a green site. And this was in order to improve infection prevention and control. We did follow a process that reviewed all of our sites that culminated in Grantham being designated a green site. Now, to do that, and we have touched on this previously when we've discussed with yourselves our response to the restore and recovery phases as an organisation, we needed to make take a number of actions in order to reduce the footfall across that designated green site. And these included changing our urgent care pathways, changing our diagnostic pathways, re-providing outpatients, and a number of other displaced services within the Grantham vicinity. We had to re-provide office accommodation locally for displaced staff, and we also had to provide some transport for some staff who were working and being temporarily redeployed to either Lincoln or Pilgrim or another one of our sites. So these changes went live during late June and early July across all of our hospital sites, with Grantham taking on the green site designation. Now, since that time, we have treated 1,094 urgent and cancer patients at Grantham, and we have delivered over 2,000 chemotherapy sessions. And we wouldn't have delivered the vast majority of this activity without this model being in place. And we have been able to reduce the waiting lists for our cancer patients. So anybody waiting for their first cancer treatment, we've reduced the waits by 40%. And the more complex patients who tend to wait in excess of 104 days, we've reduced their waiting list by nearly 80%. So we are making significant progress, and through the paper you'll see that our original aims of the green site have been RAG rated, and with the vast majority of them being green. So we are achieving our ambitions of the green site, with a few areas where we do need to take some further action, but we've explained that extensively within the paper. Since the go live of the green site model, we have strengthened the services that we offer in Grantham, in the Grantham vicinity. Our Gonnerby Road Clinic has opened the new outpatient facilities on Monday this week, which will see 9 specialties operating out of there. And we've been very clear through the paper of the additional services we have provided within Grantham, and also the additional services and specialties that haven't historically operated through Grantham vicinity, and how we have brought more activity into the locality, which does have an impact on patients across the county, which we do appreciate, and we do recognise the impact that it is having. The other thing that I'd just like to add is that we have been able to secure 2 additional temporary theatres to enable us to increase the amount of surgery that we can undertake at Grantham. We had temporary agreements in place to take those theatres, which we've now confirmed, with the first theatre expected to arrive at Grantham in November, and then the second in the new year. And that's to enable us to increase the amount of operating that we can undertake on the Grantham site. As I mentioned before, we absolutely do recognise the additional requirements that we've placed upon our patients, whether that be travelling to another site to access their care, or whether it be the additional safety requirements from swabbing and isolation that we're asking people to undertake in order to access the green site. We do know that it is putting an additional burden onto patients. We have kept choice available where people don't feel that they can or want to swab and isolate to enter a green site. We do talk to people about the risk and give them the opportunity then to go to an alternative site where they don't have to fulfil that criteria. So we believe we are offering choice, and we are offering a service for our most vulnerable patients to keep them safe. And as I said, we've increased the amount of activity that we've been able to do and the number of patients that we've been able to treat through this model, which was absolutely the objective through this decision taken by our trust board. I'd also like to thank our staff on the record, because again, we've asked staff to work very differently, and they've embraced this for the benefits of our patients. And it doesn't come without its anxieties and challenges, and we're working very closely with our colleagues to support them through this different working model. But we believe that things are settling down now, and people are enjoying working in the different ways. In terms of the quarterly review, the Trust Board did consider the first quarterly review of the model at our board meeting on the 6th of October, where we unanimously agreed to continue the model in line with the original timescales of the 31st of March 2021. And we have put in place the regular quarterly reviews. The next is planned for February 2021. Now, depending on that quarterly review, the model could change back to pre-COVID, to the pre-COVID model. The other thing I'll just point out that there are a range of criteria within the quarterly report that, if met, could trigger an earlier change to the green site model. And these are on page 4 of our report, and I believe it's page 26 of your pack. So again, just to be totally transparent, the metrics that we're using and looking at regularly to see whether we need to change the model that's currently in place. I'll pause at that point and ask Simon if there's anything he wishes to add, if there's anything I've missed before we open to questions.
Thank you, Mark. Since we reviewed the quarterly review, and no doubt you've seen from national publications, we have seen an increase in the number of COVID cases, both in our hospitals but also across the region. And of course, we are acutely aware of the very high rates in our neighbouring counties in Nottinghamshire, where we share borders and pathways for patients. And so I just wanted to draw attention to one of the key facets of the Grantham Green site model, which is around future service resilience and being able to continue to provide urgent and cancer, in some cases life-saving surgery, whilst still being able to tackle increased numbers of COVID cases at our main sites. And that is something that, as Mark says, we monitor very regularly. In fact, we have daily reviews of what's happening in terms of the changes and the potential for a second wave of COVID patients coming into our hospitals. And we will continue to monitor that as we go into quarter 3 and quarter 4.
Okay, thank you, for your presentation. In which case, I would like to hand over, please, to Ray Wootton for a question.
Thank you very much indeed, Mr. Chairman. I've got a couple of questions. First of all, may I say thank you to Mark Preston and the ULHC staff for reducing the waiting times for cancer patients. It is one of the most traumatic times in people's lives when they're diagnosed with cancer. So I welcome the reduction there. If you look at page 43, you'll see that the UTC graph line shows a steep increase in the number of people going to that unit. Do you agree with me that many people from Grantham are using that site now rather than going to their local GPs because they're unable to get an appointment and they can be seen on that site on the same day?
Thank you very much for the question, Councillor. It's true that more people are accessing the urgent treatment centre, and there are a range of reasons why that's the case. I don't know for definite, and with information that's available, to say whether it's because people are unable to access their GP appointments. What we do know, though, is that the availability of a 24/7 service increases the accessibility to people, and it tends to be an easier route for people to gain the support and treatment that they need, which will be playing a big part in the increase in the number of people going to the urgent treatment centre. Simon, I don't know if there's anything you'd wish to add to that.
Just to say, it is a phenomenon that we're looking at. We have also seen an increased number of patients who are walking into our other sites over at Lincoln and Pilgrim as well. And that's something that we're working together with NHS Lincolnshire, the CCG, to understand what of those numbers of patients may be patients that could have otherwise gone to primary care, and what is absolutely appropriate to come to an urgent treatment centre. And we're hoping to have that review completed certainly by the end of October.
Good. Thank you, Chairman. My second question relates to page 37. Ophthalmology. It's not a word which I'm very good at pronouncing, but can you tell me why there's no service listed since March? Because the ophthalmology centre in Grantham is a separate self-contained unit. And I remember many years ago going there with Dr. Kapadia to open that unit. And I've got elderly patients who are now having to travel to Boston for that service. Why is that the case?
Simon, do you want to talk through the update of our ophthalmology service that we've recently restored?
So certainly, ophthalmology is one of those services where the largest proportion of ophthalmology is not classified as our urgent or cancer care, and so therefore ophthalmic services across all our sites, not just at Grantham, were stopped and cut down to just those procedures that were required to save sight and for the very urgent. And because of that, obviously the overall numbers greatly reduced. Now at Grantham specifically, we did consider the ophthalmic area of the site continuing, but a large proportion of those patients, as you've indicated, are potentially elderly, at risk, and as well as that, would often require a number of visits. and because of that, it wasn't compatible with a green site model, in that actually it would have lots and lots of footfall, lots of patients coming onto the site, and wasn't, in terms of our initial restoration plans, going to be one of those services we could put in the green site. However, since then, we have restated some large-scale services at the Louth Hospital, and also we're now starting to put in services, as Mark described, at the Gonnaby Road Health Clinic, and that's going to give us the opportunity to increase our services substantially for ophthalmic patients going forward.
Thank you for that answer. My only concern is that the ophthalmology unit is self-contained. It sits right at the front of Grantham Hospital, so it's nowhere near the green site or the blue site. And I just couldn't understand, was it just a matter of lack of staff that you couldn't open it? Because it doesn't go anywhere.
No, it was a very conscious decision that we do have staff to be able to do that. But of course, any patients entering on site have the opportunity to go elsewhere. We know that people will go for refreshments, will go across campus. They're sharing car parks. And that's the decision that we made around reducing the footfall, to reduce that number and to increase the space between our patients accessing the sites. That's why we've made the decision to reinstate those services elsewhere, still local but elsewhere.
And just to add to that, I had a conversation yesterday with a number of Grantham colleagues who were saying the same thing, that my area, my department is self-contained, and therefore it would be okay just to continue. Yes. And at which point do you say, actually, no, we've got to move these things off site to reduce footfall? Because I had paediatric services, I had MRI services, I had outpatients, I had ophthalmology having those conversations with me, and there came a point where we needed to make a decision to say what we could keep on site to keep the integrity of a green site model operating, which did mean that we had to move a significant number of our staff and a number of services off of the site. But as we've said, we've worked really hard to secure alternative venues in the Grantham vicinity, because the last thing we want to do is to have large proportions of the population moving unnecessarily. So we did want to keep as many people as local as possible. And that's not just about Grantham, that's around all of our hospital sites and the changes that we needed to undertake.
Thank you, Mark. Thank you, Simon. Thank you, Chairman.
Thank you, Councillor Wotton. Before I bring in my next speaker, if you would like to speak, can I ask you to put it in the chat function? I can see Councillor Woodliff has his hand raised, but it's easier often to see it in the chat function. So I've got Councillor Whittington next, please.
Thank you, Mr. Chairman. Thanks, Mark and Simon, for the presentation. And first of all, I'd like to echo the comments that the Councillor Ray Wotton's just made regarding the reduction in the cancer waiting list, which I think is really welcome and really useful. And also thanks for the increased capacity on the Gonnaby Road Clinic as well. I think that's to be greatly appreciated by the residents of Grantham. And obviously, I am much aware of the fact that those are mobile facilities. So my first question is on the subject of mobile facilities. You mentioned that you're increasing the theatre capacity at Grantham. I know, because I used to work at the hospital, Grantham Hospital, that the theatre space is quite limited. Are these going to be sort of mobile external theatres? I can see heads being nodded, so I'll take that as yes, they're going to be mobile use. Thanks very much for that. But I guess the crux of my real question and just some clarification. Obviously, I'm aware, because I don't know currently where you are in terms of your levels. Are you still level 3 or level 4 now?
So the national response to COVID, in terms of the emergency response, is a level 3 for the NHS.
Okay, it's fine. But I'm guessing, we're seeing the rates going up now. I mean, I think yesterday was a particularly difficult day because I think it was the highest number of deaths since June, and the numbers. And obviously with this, they say there's a 3 or 4 week time lag between people contacting COVID and potentially, unfortunately, it resulting in a fatality. First quick thing is, at some point, I'm guessing you potentially are assuming the worst, and you may go back to a level 4. And I just want to ask the question around, we're going into winter, and obviously you have a winter plan, and I guess at some point in the future you'll be bringing the winter plan to us for us to go through. But what pressures do you see potentially if you go to level 4 on COVID, and what impact that might have upon your winter plan? And associated to that, the question of testing as well. Do you think if you do sort of see an increase in the number of both patients potentially and also staff needing COVID tests as we go into the winter, have we got enough testing capacity? What pressure will it put on your winter plans? And also on those medical beds that used to be at Grantham, which obviously are now elsewhere, because I think the majority, I got the impression when my mum was in there that a large part of the cohort are elderly people who may have had a fall or something. Have we got the capacity to deal with them? And presumably that they will have to go elsewhere from Grantham. So those are the questions around kind of winter level 4 COVID and staffing. And I think that they are all kind of mixed up in one, if you know what I mean. It's just COVID, winter, the medical beds, and have you got enough ability to test for COVID? Thanks, Simon. Thanks, Mark.
So thank you for those questions, and they are very testing questions, and they're things that we are considering on a regular basis, because there is no easy answer to those that you pose, but we'll do our best to share where we currently are. So if I start with the medical beds and testing, and then hand over to Simon with regards to the challenge that's going to be the next 6 months. So in terms of medical beds, we have been working really hard to increase the number of medical beds across Lincoln and Pilgrim. We do have extra capacity available to us. Now, with that available capacity, though, typically it means that we're able to stand still. And by that I mean, because of if you have an outbreak, if we need to do some additional infection control prevention works, we're able to keep our bed base relatively static rather than having to reduce our bed base. So we have increased them overall, but our operating bed base on a day-to-day basis is remaining relatively static because of dealing with outbreaks or infection control issues or estate issues. We are looking to put in place from the beginning of November a green site rehabilitation model. So to have a number of beds at Grantham that we'll be able to repatriate people from the local population of Grantham back to Grantham onto the green site and under a rehabilitation model, like I said, from the beginning of November. Now with that comes some challenges, because we don't have necessarily open visiting on the green site. So there will be a choice for people to make about whether they wish to go more local to home for the rehabilitation and the medical beds, and then what that means from a visiting perspective. So there will be a bit of a trade-off for us to keep the sanctity of the green site model. So I think that tackles the medical beds question. The second one, with regards to testing, this is going to be, has to be the central point of our approach going forward through winter testing. And we have to find a way, and I know nationally it's moved up the agenda to have more regular testing of staff, because we've got to ensure that we don't have asymptomatic staff who are spreading potentially it to patients or to each other amongst the hospitals. Because we are seeing a range of outbreaks across the country related to people sharing it, despite having PP or socially distanced or hand washing, because people aren't always consistently applying those measures in the hospital setting. So testing has to be a really central part of our response during winter to help keep patients safe, the community safe, but also our staff as well in terms of their health and well-being. So Simon, I don't know if there's anything you wish to add about medical beds or testing, but I'll hand over to you for the winter plan.
Thanks for that, Mark. So both those will feature in what we're calling our phase 3 plan. So we realise that winter is just one of the 3 challenges that we're going to face between now and Easter next year. The first one obviously is the traditional increase in demand and also dependency of some of the patients that access our services over winter. The second one obviously being how we would manage COVID in that context. And how we will continue to isolate COVID and suspected COVID patients from those other patients that are not but still require urgent care. And of course, the third thing in that mix as well that we need to consider is some of the impacts of EU exit and what that might do as we leave the EU exit system. So all of that's going into what we call our phase 3 plan. We're not having a separate winter plan this year because we need to consider all of those things. But they build in how we will manage our bed base, how we will balance the risk across all of our sites, making sure that we reduce the chance of contracting COVID to the very bare minimum. And having recently worked with NHS England and improvement regional teams who have been sort of testing our plans, we've had feedback that they are robust, and they are one of the more robust in the Midlands and particularly in the East Midlands, just because of the nature of our hospital setup and our ability to be able to deliver a model like the Grantham Green site. Going forward, I think you in terms of the testing capacity, we have the second largest set of labs in the East Midlands at our disposal, and they have responded tremendously well over wave 1. But we also realise that they have been running in excess of 100% capacity now for more than 100 days. And so therefore we are building in elements of resilience and working with national and regional procurement teams to make sure that our equipment and our capacity remains at that level or increases depending on the availability of some of the reagents nationally as well that might help us do that.
Thank you very much indeed, Mark and Simon. And if I may, Mr. Chairman, the news of the green side rehab at Grantham from November is very much welcome, and I thank you for it. Thank you.
Thank you, Councillor Whittington. Okay, I'd like to hand over to Councillor Woodliff.
Can you hear me?
Oh, can
you see me? Can you hear me? Thank you, Chairman. Can you hear me?
Yes, we can. Yes.
Good. Okay. It's not been working very well here. 2 questions. The first is, I note from the report, Mark, that it's possible that the Grantham site might be made into a permanent green site. I understand there's some discussions over that. That's really the first question. And the second question, I'll put it together. Is it possible to create green sites in both Pilgrim and Lincoln to give flexibility? The thing that concerns me is that we have 1 pandemic at the present minute, but we could have 3. It's nothing to stop Ebola or dengue or any of the others appearing on the scene at the same time. So what plans have ULHT got for that? What do they think? Is it possible to create green sites in the other 2 major hospitals, or is that too great an expense? What happens, for instance, if Grantham becomes compromised? So, have you considered that? Over to you.
Thank you very much for your questions. And yes, we have considered those things. The first question about Grantham becoming a permanent green site, that's not wording that I would recognise. We've said that from the 31st of March up to the 31st of March is our initial expectation for a green site, and we'll review that quarterly. And we've always said that depending on the context in which we're operating in, it may be required to be extended past that, but that would be subject to the quarterly reviews and the pandemic and the context in which we're operating. From a a response from a Lincoln and Pilgrim perspective around green sites, we do have green pathways operating at Lincoln and Pilgrim. That it's not a green site where we have reduced the risk across a section of our hospital. What we are doing, though, is asking people to take additional precautions on a pathway. Now, with that becomes a smaller amount of risk, but there's risk nonetheless, because we can't, because we did look at this originally when we looked at all the options of could we zone an element of Lincoln to make it just a green area with shutting doors and isolating staff to a particular zone. We had the same conversation at Pilgrim. But unfortunately, the way that our theatres are configured, where our diagnostics are, etc., we just couldn't self-contain a zone of each of the sites to say that's an allocated green zone at Lincoln, an allocated green zone at Pilgrim, and the same at Grantham. So that's why we had to go down the route of allocating one of our sites as a green site. So like I said, we have green pathways. We take as much precaution as we can for those patients that need to go through the Lincoln site or the Pilgrim site because of complexity of surgery. In terms of have we considered if we have a nightmare scenario of other pandemics, that's something that we continually evaluate through our major incident response, and it would be something that would change our current response to a single pandemic, and we would have to look very differently to how we would deliver services across our hospital sites if we were entering a nightmare scenario of multiple pandemics at the same time. I would guarantee it wouldn't be the current model that we would operate if we were in that scenario, because it would literally be back to the drawing board to understand how we can best keep our patients and communities safe, and how can we balance that off with treating the most number of patients that we need to treat in order to address this balance of a pandemic need, but also an urgent need for treatment for the public. And that's what we're trying to do through all of this, is to find that balance between both of those populations. And I think as an organisation, the staff and colleagues have responded extremely well. And there's more obviously we'd like to do, but I think we are getting to a place where we are balancing those needs out at this moment in time. Simon, is there anything you wish to add?
Oh.
No.
Well, thank you very much. I think I've got no criticisms of you. I think as an exercise, you've carried it out brilliantly. But there is the possibility always of other things occurring. We don't know what's behind COVID-19, whether it's deliberate or whether it's just accidental. We live in a very dangerous world. And in the 1970s, we were all concerned about nuclear weapons. But of course now, there are other things going on, aren't there, which are far more dangerous in many respects. And we don't know quite what would hit us. But this has been a very good exercise in many respects. And I do commend you for all the work you've done and your colleagues. I think you've done brilliantly well. So thank you very much.
Thank you for that.
Thank you, Chairman. That's my two questions. Thank you very much.
Thank you, Councillor Woodliff. Currently, I haven't got any further speakers, so I will ask my three questions I have. The report to the ULHT board refers to Grantham's green site operating at 29% below the predicted surgery activity levels. Do you expect the surgery activity levels to increase over the coming months? If so, will this impact the timescale of reverting back to normal activities on the 31st of March 2021? And what are the reasons for it not being achieved as expected?
Simon, do you want to pick up the surgical question?
Yeah, sure. So, yes, we expect that to increase, and part of that will be, as Mark described earlier on, the increase in overall theatres available and extending the theatre complex. By doing that, it gives us a greater degree of flexibility between the specialties that we can operate. Some specialties, for example, can only use 2 of the 4 theatres that we have available because of the increased mechanical systems that are in those theatres, and these 2 additional sort of semi-mobile, so they come on a lorry and then they're installed onto a base, will give us 2 more of those types of theatres, and that will increase our flexibility. By having more flexibility, we'll be able to increase the number of cases that we can offer over at Grantham. The other challenge that we faced, and one of the reasons why we've not been able to increase the numbers quite to where we expected, was the case mix of patients that we've had, certainly initially in the first perhaps sort of 10 weeks of being able to operate, were cases that were very significant, were complex, and because of some of the delay that they'd incurred, we were having to take longer on some of those cases. And this is in the context also of our surgical teams having to take extra precautions. So we use PPE in theatres normally, but the level of PPE that we had to use, certainly in the early stages of when we were working the Grantham model, was taking more time because we had to put all of that equipment on, take it all off. And if you times that sort of by 10 or 11 cases per day, it was significantly increasing the downtime of theatres, reducing the number of patients we could get through theatres. I'm pleased to say that's getting better, and as you can see, the numbers have increased. They've got to a place of almost plateauing now, and that's why we know we need these additional theatres in order to be able to increase that activity. In terms of your other question, Councillor, is around, would that then affect the reversion back to previous model? And if we were able to very significantly impact on our waiting lists and reduce those down, one of the key criteria that we've described in the report is the revert back to, or certainly the consideration back to the pre-COVID model before March. And we will monitor that. That said, at the moment, the way that our waiting lists are, we would have to do substantially better than even the 100% of what our expectations were in order to be able to catch up with that waiting list. Partly because we've started to see a very healthy and a good number of patients now starting to come through being referred from primary care, and we're now reinstated a huge addition to our waiting lists as people are starting to use health services in a way that they weren't during the first stage of COVID.
Okay, thank you for that answer. My second question is, on page 43, the second paragraph, it states you've been unable to quantify the proportion of patients being displaced to other trusts. What measures are being taken to include these and in turn give a much clearer picture of the situation? It is already concerning that large number of patients have already been displaced, both Lincoln and Pilgrim.
Simon, do you want to take that one?
Yes, certainly. So the original forecast of displacement of patients to predominantly North West Anglia Foundation Trust and to Nottingham University Hospital as our nearest other trusts was forecasting in the sort of single figures per day in terms of the impact on those sites, and we've put in place weekly sessions with those trusts to make sure that that's not overburdening. Well, that's one of the reasons why we put in there a criteria that says if those trusts are overwhelmed and they require mutual aid from us to be able to stop the drift of patients to those other trusts, then was one of the reasons why we would reconsider putting the previous model in place. I'm pleased to say that certainly the weekly sessions that we've had to date haven't indicated that such significant numbers have been going through, and in fact actually haven't even been indicating the numbers that we set in the original plan. Unfortunately, being able to get all of those numbers because they move out of region and into other organisation and then get those numbers back into the report, we weren't able to get those completely accurate in time to get them through this report. What we didn't want to do was delay the report because we wanted it to be a quarter, but of course that meant that we only had a couple of days in order to prepare the data and put it through to our board in order to be reviewed. We do expect that for future reports going forward we'll have all of that data available to confirm the statements that I've just made around not disproportionate numbers moving out of region.
Yeah, I think that would be very helpful for this committee to see, because potentially you could be looking at 1,400 people additionally going out throughout the year to these trusts. And I think when you add into the picture what you've already shown in the statistics, that is quite concerning. Okay, I'd like to move on to my final question. On page 51 and 52, the report lists the additional expenditure to offer services closer to home due to the current arrangements at the hospital. Where is this additional money coming from? And will this have an adverse effect when the services are able to return to Grantham Hospital?
So thank you very much for the question. The money has been secured through the national route as part of the initial COVID response, and that's helped us to re-provide these services across the Grantham vicinity. And no, they don't. Having these arrangements in place will not affect the services going back into the Grantham Hospital site. We're committed to returning services back to Grantham as we've previously outlined.
Okay, thank you. I haven't got any other speakers that have came forward, so I'm going to move to the proposal. I would like to propose that we commend the Trust and its staff on the increased number of oncology, haematology, urology and maxillofacial patients being treated at the Grantham Hospital Green site, to put on record the committee's view that the reviews of the Grantham Hospital Green site by the Trust should be more frequent than quarterly, given that the Green site is operating 29% below the predicted capacity, and also the expected increase in COVID-19 cases in the coming months. I'd also like for the committee to receive information in regards to the displacement of patients to neighbouring trusts as soon as it is available. Do I have a seconder for that proposal, please? Thank you, Councillor Brewis. Thank you. All those in favour, if you could please switch your camera on and raise your hand.
Could I ask anyone that isn't a member to switch their camera off, please?
Have you got everyone, Trina?
Yeah, that's, I can't see, yes, Councillor Whittington. I can't see his picture yet, but
I think I've got problems with my camera, Katrina, but I am in favour. Thank you.
Okay, that's everyone then, Chairman.
Thank you. That's unanimous then. Thank you. In which case, I'd like to thank our presenters before we move on to the next item. I'd like to now move on to agenda item 6, the non-emergency patient transport service update. This is on 83 to 89 of the agenda pack, and I'd like to welcome our presenter, Tim Fowler, Assistant Director of Contracting and Performance for the Lincolnshire CCG. Is Sarah Jane with you as of yet, Tim?
No, she'll join for item 7, if that's okay.
That's absolutely fine, no problem. In which case, we also have Gabriella Urquhart, Lincolnshire Clinical Commissioning Group, in the appointment observing this item. And if anyone wishes to ask questions or contribute, please type speak in the meeting chat after Tim's had the opportunity to present. So if I give it over to you for about 15 minutes maximum, Tim, and we'll take questions again.
That's fine. Yes, thank you, Chair. You have the paper under agenda item 6, and I'll just take you through that. There are 3 points that I want to pick up on. One is the update on the response through COVID, and just talk through that for a while. I want to talk about activity and performance, and you've got attached as an appendix to the report the activity and performance up to August. And then I want to talk about planning for future arrangements. I think, as people know, the contract finishes with TASL in June 22, and the CCG is well aware of that and wants to start putting in place the planning arrangements for what happens when we reach that date. So if I just take you through the report, I'll take the report as read, if that's okay. I think we all recognise, and you'll have heard from ULHT in the previous session, that COVID has caused quite a lot of issues for us, and not least to patient transport services. The report that you've got covers the peak COVID period and the period when we started to restore services. And that's created quite a few challenges for patient transport. In the very early days, there was guidance issued by NHS England, NHS Improvement for patient transport, and that came out on the 27th of March, and we reacted to that. and that included measures to support transport for COVID patients, which included the suspension of eligibility criteria, asking patients to use their own transport, setting priority patients for access to transport, requirements for rapid discharge, suspension of KPI penalties. That KPI penalty suspension is perpetuating, continuing up until the end of the year. And then certainly in Lincolnshire, we were required to work with EMAS to have a coordinating role for patient transport during the COVID period, although EMAS in Lincolnshire took quite a light touch approach to that. There were lots of issues to start with in terms of organisation, processes, PPE, themes you'll be familiar with. Generally, we feel TASL have stepped up. They responded well to the COVID period, the peak COVID period, and we worked really closely with them. They became part of the cell structure that we had in Lincolnshire to manage COVID, and generally, I would say that they worked well. Lots of issues about how we socially isolate patients on vehicles, lots of issues about COVID testing of patients before they came onto the vehicles, lots of issues about keeping staff and patients safe while they were undertaking journeys, and working with the quality team at TASL, working with the operational management at TASL, we've managed to respond quite well. Having said that, the activity that was taking place during the COVID period was about 30% down on normal activity. That's because, as you are aware, or should be aware, the Department of Health decided with NHSE and NHSI that elective surgery that wasn't urgent, outpatients and diagnostics that weren't urgent wouldn't take place during the peak COVID period. And that meant that there was a reduction for April, May and June of about 30% in the number of journeys that TASL were doing. However, during that time also, because of the social distancing, whereas previously they might have had 4 or 5 or 6 patients on a vehicle, they could only perhaps have 1 and sometimes 2 patients on a vehicle, particular relevance to discharges and particular relevance to patients who are on stretchers. So lots of issues to work through there. There was also the fact that TASL had to clean down the vehicles after each journey. And within that takes about an extra 15 to 20 minutes to clean down during the peak COVID period. As we've started to restore services, TASL have seen an increase in the number of journeys that they're undertaking. And I think that's caused a number of issues. Again, because of social distancing on the vehicles, and in some respects, vehicles having to do greater journeys, greater distance of journeys. And we're working with TASL to make sure that they can respond to that as we restore in a really positive way. I think they've had a few hiccups around that, but generally it's looking okay at the moment. Just to highlight that as part of the restoration, you've heard the previous report around the Grantham Green Hospital site, and as a temporary measure, we've put in some secure transport to Grantham Green Hospital site in conjunction with ULHT. We haven't given that to TASL. We've contracted that out to an alternative provider. And in doing that, what we've tried to do is support TASL to maintain services into Lincoln County, Boston and other hospitals. That's generally working well. That system into Grantham and out of Grantham with that provider is generally working well. We've had very few concerns about that. That's been in place since July, and we're quite comfortable with that. I guess the other point to raise is renal services. We've had, because of the need to protect patients who are very vulnerable, renal patients who are very vulnerable, we've had to change the pick-up and collection times of patients going into the renal unit, particularly at Lincoln County. And that's created 1 or 2 issues for TASL. Meant that they'd had to pick patients up at very specific times. and collect patients at very specific times, and within the unit make sure the social distancing between patients. So whereas in the past they would have patients in a waiting area, that can't now happen, nor can they have different patients on the same vehicle. We are working through with the renal unit some of the initial problems that we had, and that seems to have resolved now, although we're not completely out of the water on that. Having said that, the transport service for Boston, Grantham, Skegness satellite units seems to be working well and worked well through the COVID period. If I pick now on activity and performance, you've got the activity report and you've got the KPI performance to August in the report as an appendix. For the period up to August, we've got 3 new KPIs that we introduced in February. I don't think these have been reported before to the committee, and they are for rebeds. We were concerned about the number of rebeds that were taking place, and we've now got a KPI which is being reported in line with national guidance. We can't invoke penalties on these at the current time, but that KPI is in place. And there was another concern that we had, which was around the length of time patients were waiting in hospitals to be picked up in discharge from outpatients, and we've got 2 KPIs that are being reported for that now. For August, the month of August, TASL achieved the contracted level of performance for 2 out of 15 KPIs, and they improved month-on-month improvement for 2 of their KPIs. I think the committee knows that we've had, over the years of TASL, we've always had issues with them performing against contracted KPIs, and particularly during the COVID period, and we've started to restore those KPIs, picked up a little bit through the COVID period, as you'd expect with reduced activity, but then reduced back again to more normal performance, which is not where we want it to be, but more normal performance during July, back end of July and August, as we started to get back to more normal levels of activity. Some of that is due to social distancing, and we need to see how that works through September and October, and we're in discussion, very detailed discussion with TASL about what more we can do as a collective to try and get that performance improved. Having said that, we are not seeing significant noise from any of the hospitals that we deal with, or significant noise from patients at this point in time. If I then move on to planning for the service from July 22, I think the committee will know in the past that we've said that what we are keen to do is have a really long, hard look at patient transport services as we start to put in place the planning for 22. And what we're keen to do is have a integrated transport service in place, which would move away from the current very, very narrow focus on patient transport services. And what we want to do is try and get greater integration with public transport so that patients are supported, if they're not eligible for transport, to have other alternatives signalled to them. That links back into the acute services review and some of the changes that will happen for the configuration of services around the county, health services around the county. The contract at the moment is due to end. It was let for an initial 5-year term, which ends on the 30th of June 22. There was a 2-year extension included in the contract, which would take it to 30th of June 24. At this stage, we do not expect to extend the contract, which means that when we reach June 22, we would have to go out for a procurement process. We know there are other competent providers in the marketplace, and we'll start doing the planning for that now. You've got a draft timetable for that.
Tim, I'm not sure if we've actually lost you. Members, quite clearly at the moment in time we seem to have lost Tim Fowler. We'll hang on just to see if he needs to log back in for a few moments.
Hello?
Hello?
Chairman, it might be worth you asking him to turn his camera off.
I will do. Tim, I don't know if you can hear us, but it might be better for you to turn your camera off, and then we may be able to at least get your audio. You try that, please, if you're still in the meeting. It does look like he's now dropped out entirely. We'll just wait on a few moments to make sure if he can log back in or not. Simon Firth, I don't know if you're there, and perhaps if you could help try and move this forward. Thank you.
Chairman,
Hi, Trina.
has we haven't got him coming back in. Do you want to pause the meeting or?
I think it'd be best for the moment in time to pause the meeting. I'm not sure whether or not we should just allow the recording to continue for the time being and just insist that people keep the microphones off until we can get in contact with them.
Okay, Chairman.
Thank you. If members would like to take a 5-minute recess, please feel free to do so, but please do not leave the meeting. Just keep things on mute and video off for the time being. We'll hopefully reconvene for about 11:10.
We're back live, Chairman. Do you want to do a roll call?
Yes, please. If you could do another roll call just to ensure that everyone's still within the meeting, that'd be helpful. Thank you.
Right then, members, if you could please confirm that you're still in the meeting. Councillor Suzanne Barker-Milan.
Present.
Councillor Bill Bilton.
Sorry, present.
Councillor Chris Brewis.
Present.
Councillor Matthew Fido.
Present.
Councillor Mrs. Sandra Harrison.
Present.
Councillor Carl Macy.
Present.
Councillor Robin Renshaw.
Present.
Councillor Angela White.
Present.
Councillor Mark Whittington.
Present.
Councillor Stephen Woodliff.
Present.
Councillor Ray Wotton.
Present.
And Dr. Brian Wookey.
Present.
So everybody's present, Chairman.
Thank you, Trina. Apologies to those of you that are listening online at the moment. We've had some technical issues. We're currently on agenda item 6, the non-emergency patient transport service. And I'd like to hand back over to Tim Fowler from the Lincolnshire NHS CCG, please, for the presentation.
Thank you. Again, my sincere apologies to the committee for the gremlins in the technology. I think when I lost it, I was just talking about the planning for the patient transport service from July 22. I think as the committee will know, this contract with TASL was originally let on a 5-year basis from 2017. That would mean it would end on the 30th of June 22. There is a 2-year extension written into the contract, which is up to the CCG to exercise. And we are not going to, at this stage, exercise that extension. That means that we will go out to procurement, and TASL, if they want to continue with the contract, will need to bid for the contract from the time that we go out for the procurement. There is a draft procurement timeline within the paper that you have. I don't intend to go through all the dates in there. They're there to be looked at. This may change, but at the moment we consider that we'll do planning up to about February. We'll do the procurement through to probably July or August. And that will give a significant time for a new provider or TASL as a provider to mobilise the new service. I think one of the lessons we learned from last time we went out to procurement was that we didn't perhaps leave enough time for the mobilisation. So we're trying to build in a bit more time there. What we're also wanting to do is spend a bit more time on the planning so that we get the specification robust. And also integrate into that some of the work that we want to do around having an integrated transport service. We are very well aware that at the moment we see patient transport very much in isolation. We want to make sure that we link with the county council transport service so that where patients are ineligible for transport, they can be signposted to some of the services that the council provide for transport, so we can get patients to and from the new services that will be provided in different locations around the county. I've got really nothing else to add to the report. I think just in summary, TASL stepped up during the COVID period. We were pleased with the way they responded. We have some concerns about going into winter and what that would mean, and we have seen that downturn in performance as we've gone through the start of the restoration period. We will work really closely with TASL through the coming months to make sure that patients get the service that they should have, and to make sure that our hospitals and our providers are supported. KPI performance has been mixed. We're not at the contracted levels. That's been a recurrent theme throughout the contract, as you know, and we are planning now to set up the service, look at how we would engage with patients and providers to make sure we've got the right service in place from June 22 onwards. So I can leave it there and perhaps take questions.
Yeah, thank you, Tim. That's much obliged. I will hand over for the questions. So I've got first, Councillor Ray Wotton, please.
Thank you, Mr. Chairman. Thank you for your report, Tim. In fact, you highlighted many reasons why campaigners in Grantham want people treated locally in their local hospital in Grantham. I had a 8-year-old lady contact me this week who, because of the ophthalmic closure in Grantham, has had to travel to Boston. She received transport through Tassel on 2 occasions, and yet her appointment on Friday this week, she didn't fit the criteria. Fortunately, she's going to be taken now. Why has the criteria changed? And also, do you recognise that people travelling 25, 30 miles may not have any transport at all to get to these appointments, and they can't afford taxis to get there?
So if I deal with each of those in turn, so I'm not aware that the criteria has changed. That's not prompted by the CCG if it has changed. Without knowing the detail of the individual, I can't really comment further on that, but if you could let me have the details of the individual, I'm more than happy to take that up with Tassel. We have had, I've had knowledge of 1 or 2 patients who've had transport provided in the past, and then through Tassel changing the criteria or applying the criteria differently, they've then been told that they can't have transport. When that happens and we're aware of it, we will take it up with Tassel. So if you could let me have the details of that, more than happy to take it up and find out what happened and report back to you. Your point about patients having to travel further distances, yes, fully recognise it. There are patients who, through no fault of their own, will have to travel further. That's about the reconfiguration of services in Lincolnshire. It's also about, if we take Grantham Greenside, we know that we've got patients making longer journeys into Grantham Greenside. That's a balance that we have to strike. When we get into planning for the restoration of services, and when we get into planning for the change in the contract from June 22, what we want to do is make sure that patients have as much opportunity as they can to get the transport to the services that they need to access. There is a national eligibility criteria currently, and we are obliged to apply that, and that's what we do. However, what we're working with at the moment through Lincolnshire County Council connections is trying to plan for how we would allow patients to get to services that may not be very, very close to their home, and trying to work that through in a much more kind of integrated and connected way. There is a review that is undertaken, has been undertaken by Simon Stevens, the Chief Executive of NHSE NHSI. We're expecting, that's into patient transport services, we're expecting that review to report round about the end of November. And we've got a session with NHSE NHSI on the 24th of November to look at the initial findings of that review. And what that may do, that may alter some of the eligibility criteria that's applied. I hope it does, because the eligibility criteria at the moment is a little bit confusing, but I can't predict the outcome of that review. So I think it's a point really well made. We are aware of it, and we are trying to work to a point where we do improve the accessibility of services to patients, albeit that may not be on a patient transport vehicle.
Good, thank you, Chairman.
Thank you, Councillor Wotton. I now have Councillor Whittington, please.
Thank you, Mr. Chairman, and thanks, Tim, for your presentation. I'm not particularly going to go in too much into the present sort of contract with Tassel, because I know it's been fraught with difficulties over the term it's been in place, and I think the decision at the moment not to extend the option for the further 2 years, I think kind of speaks volumes really for the sort of disappointing level performance has been. I mean, I appreciate your comments that the Tassel have stepped up during COVID, and I guess it's difficult looking at the KPIs and activity stats because of the impact of COVID. I appreciate that maybe there has been some deterioration, but I want to kind of look to the future. and potentially what a new contract might look like. I'm pleased you're going in to sign the procurement process 18 months out from its start. I think that's good, and because it's going to take time trying to put this in place. I think one of my questions has kind of been alluded to in some comments that you made to Ray in your previous answer. I'm guessing that obviously we don't know how long COVID's restrictions are going to go on for, and there is the reconfiguration of the services, and I'm guessing that we know the patients are going to have to be potentially travelling more. I imagine there's going to be quite a volume increase in the new contract. I mean, I think that's probably read, and I'm just wondering, bearing in mind some of the problems we've had with TASL in terms of patients having to wait and cancellations. What sort of volume do we think the reality is the new contract's going to have to deal with? Because it seems as if the present TASL contract has difficulties dealing with the existing volume, hence sort of the numbers of cancellations we've had. And going forward with the reconfiguration of services, that'll be a further increase in volume. And I'm just wondering, are there any providers out there that could possibly deal with this increase in volume and give guarantees? The patients who've got transport booked will be able to access it on the day, won't be cancelled. They won't have excessive waits at hospitals. So just some feel, Tim, as to what the market's out there. Are there other providers who could fulfil the terms of this new contract? What would TASL have to do? What would they have to demonstrate to you and to the CCG to be considered for the new contract? I appreciate the comments, and I think they're welcome working with the Call Connect. I'm guessing you're referring when you speak about the county council, you're referring to our Call Collect service. Yes. So that's thanks Tim. So that's to be welcomed, and I guess that potentially there may be a mixed model, which begs the question: is this a service that could be brought back in house, jointly between the CCG and the county council? And one issue, and I know it's going to be discussed further down regarding Vale Medical Group. That practice is in the division I represent, and already I've had people contacting me saying that if the closure does go ahead, potentially they're going to have to sort of travel from Woolsthorpe over to Crowson. And that's flagging in my mind. Well, Crowson's in Leicestershire. Do TASL do out of county, or would any provider do out of county? And I'm also thinking as well that I know some patients from Grantham attend hospitals in Nottingham, Leicester, Peterborough. So, and I don't think I've ever asked a question before about out of county. So just some clarity around that. And also, again, it's things like potentially Vale closing. That's going to increase the volume potentially of people who may need transport. Would it cover people whose local GP practice has closed down and have to travel? Because obviously we've got, here we've got potentially, we've got the Lakeside issue at Stamford as well. We've got the Vale. Especially I'm thinking about elderly, vulnerable people who don't necessarily have access to cars. Public transport is, in some parts of the county is negligible, and I'm just wondering, with all this sort of going on, and which I think comes back to the first question around the volume and potentially big increase in volume. So thanks, Mr. Chairman, okay. and thanks, Tim.
Okay, so the number of elements of that, I think. The first one I'll pick up is the out of county issue. So the patient transport provider is contracted to provide patient transport for all Lincolnshire registered patients. So if a patient is registered with a Lincolnshire CCG practice, TASL will provide currently will provide the transport to that practice's patients. They go through eligibility criteria first, and I've spoken a little bit about that. TASL at the moment will take patients through to Peterborough. It'll take patients to London, to Sheffield, to Manchester. So they do the out of county journeys. That creates an issue for us in the out-of-county journeys mean that if you've got a vehicle going to London, that vehicle isn't available for work within the county and supporting, for example, discharges from Lincoln County or from Boston. And that's caused us a little bit of issue. We are hearing, and I don't know if it's definite yet, but one of the options being considered in the national review is that you would have a patient transport provider who would just deal with your local hospitals, irrespective of where the patient is registered. So if we've got a Sheffield patient in Lincoln County, for example, our local patient transport provider would take that patient back to Sheffield, even though they're not a Lincolnshire registered patient. Don't know how that's going to work out, but that's what we're hearing might be being one of the options for the review. In terms of the volume and are there other providers out there who could do this and do it in a more robust way? I think it's fair to say that nationally some of the patient transport providers in other areas have been struggling. I don't know the full detail of that, but that is one of the reasons why we've got the national review. In terms of volume, TASL in a normal month pre-COVID, we're doing between 10 and 13,000 journeys a month. There are two aspects to that. One is the individual number of patients that they take on the vehicles. The other aspect to it, and I picked it up in the report, is the number of individual vehicle journeys, and the two things are different. What we've seen now, and all transport providers have seen this, is that because of social distancing, there is a greater increase in the number of individual vehicle journeys, whereas in the past you would have 3, 4, 5 patients on a vehicle. Now you may only have 1 or 2 because you have to have social distancing. That will continue through the COVID period, and none of us know when that COVID period will end. And we've seen spikes recently in Lincolnshire and other areas, and in particular Nottingham. That makes planning for a volume for the contract really, really, really difficult. And we will need, when we put the new contract in place, we'll need a very flexible approach. My thoughts at the moment are we will link that into cost of provision in a way that we haven't done at the moment, rather than just link it into an activity-based contract, but all of that's to be decided. You asked a bit about how we would work with primary care. Primary care at the moment, taking patients to GP practice is a national exclusion from eligibility for patient transport services. However, we are aware, and I'm sure Sarah Jane will cover it when she comes on to Vale, we are aware that when we close a branch surgery, getting patients from point A to point B is really concerning and really uppermost in the minds of patients. But I'll leave that for Sarah Jane to cover, if that's okay. I think that making sure that the contract is robust and are there providers out there that are interested. We understand that there are a number of providers who would be interested. I won't say too much about who those providers are, but we know that where there have been recent procurements of patient transport services, there have been a number of providers who've been interested in responding to that. Having said that, most of that was pre-COVID period, and I don't think anybody has tested the market since we've been into COVID. I would be relatively optimistic that there are providers out there who could provide a robust service to us. You then have to balance off the cost of that service against the level of provision that you have, and that's always been an issue. And as you know, the NHS hasn't got a magic money tree, unfortunately. However, patient transport is really important, and my own view is we need to fund it properly. I think the final issue was around whether we could perhaps in-house the service, and I don't want to pick up on that at this stage. Obviously, we have a procurement that will go live early next year. It is an option, but I wouldn't want to prejudice any of the procurement discussions around that by answering that as a definite yes or no at the moment. I think that's to be explored. I hope that answers the questions.
Yeah, that's fine, Tim. Thanks. I appreciate it around the in-house option. You have to, you can't be too specific on that. I appreciate that. I guess as the procurement process goes on anyway, you'll be reporting back anyway, and we'll be able to ask questions at that stage. But thanks, thank you, thanks.
Thank you, Councillor Whittington. I have two speakers that have said they wish to speak. So after that, I've got some questions, and I plan on closing down the debate unless someone else comes in the next few moments. Okay, Councillor Brewis.
Thank you, Chairman. I think one has to be grateful that perhaps it's not as disastrous as it was sometimes in the past with the TASL stuff, and I find this particularly interesting, particularly the involvement with voluntary car schemes and our very fragile network of public transport in Lincolnshire. I have just been interviewed by Sistra as Lincolnshire has been selected as one of the candidates to explain how public and transport, including things like TASL, work in a largely rural county. But my bother is at my end, we've got a very successful voluntary car scheme, but those are now threatened by the fact that so many of the drivers are elderly and are now reluctant in the current crisis to take people to hospital. So I see a tsunami of extra demand coming over the horizon, and it's really to ask Tim whether they're aware that this could be where an awful lot of people, the people who have currently been involved peripherally in voluntary car schemes will no longer be able to do that because they're frightened to take people to hospitals and things like that. So are they aware of that tsunami of extra use that is already arriving and probably going to get a lot worse?
Absolutely. It's a real concern for us. I think you know my view, and we've discussed it before at committee, that voluntary car drivers have been absolutely essential and incredibly valuable to the service that's provided in Lincolnshire. As you know, 3 years ago, TASL decided that they would not perhaps work productively with the voluntary car drivers. Fully understand that voluntary car drivers, a number of them are retired and therefore will be concerned about taking patients who are potentially COVID positive to hospitals or going into hospitals as a kind of a car driver themselves. We have flagged this with TASL. They are aware of it. I'm not sure there's an easy solution to it, particularly given the other demands on the patient transport services, but we are aware. And we are trying to work with TASL to put extra capacity in. One of the reasons for not using TASL for the Grantham Green site was that we were seeing a downturn in the number of voluntary car journeys that were being undertaken. So therefore we supplemented the TASL service, if you like, with a different provider doing Grantham Green site. So yes, very well aware of it. It's a national issue. It's not just a local issue in Lincolnshire. It's probably more prevalent in Lincolnshire, given the rurality. But yes, very well aware of it. But I don't think there's an immediate or easy solution to it, other than trying to increase capacity in the core service.
Yeah, thank you very much. It's a very, very difficult one, we know. Thank you.
Thank you, Councillor Brewis. Okay, I now have Councillor Woodliff.
Can you hear me? Oh, you can. Thank you, Chairman. Now, Tim, could the contract be split up rather than having one, so you can give perhaps smaller operators a chance to contribute? It would give flexibility, and it would enable an inefficient operator, if one appeared, to be dispensed with more easily. If you have just one contract and one operator, you're really held to ransom by that one operator. But if you have a series of contracts, which I think you alluded to actually in the last statement, whereby for Grantham you had another operator provide a service, if you can split the contract up, you have more control, I think, over what happens. And it gives smaller operators the opportunity to contribute to providing a service. So have the procurement officials considered that particular option?
So we are considering that. One of the options that will be considered for the procurement is to procure in lots. There's always a balance to be struck between the number of providers and the efficiency of the service. And with patient transport, that's particularly relevant where you have a call centre. So what we wouldn't want to do is have, for example, 10 or 15 providers with each with their own call centre and patients having to ring a different number for each of those providers. I don't think that would work very well. Our examples of where we tried that before on a kind of a very small scale is it doesn't work. The Grantham Green site transport is very much coordinated through United Lincolnshire Hospitals, so that works quite well. And the discharge support that we've got at Boston and at Lincoln County, 2 crews, 7 days a week in there, which again is not provided by TASL. That's under the control of the site managers at Boston and Lincoln, and that works quite well. When you start to talk about outpatient journeys out of county, etc., that doesn't work so well if you have a multitude of providers unless you have a single call centre they can all access. So I would see the front end of that service, the call centre, having to be with a single provider. I wouldn't rule it out in terms of having more providers or going out in lots. What we could do is go out in one lot for discharge, one provider for discharges, one provider for taking outpatients in and out of hospital. There's a bit of inefficiency in that, given on how we would use the vehicles. But what I wouldn't want to do at this stage is consider having, for example, 20 or 30 transport providers. I think this is different to how some of the school transport works. It's a different way of working and linking to the hospitals in a very, very kind of integrated way. But it is a consideration, and I will feed it into the procurement process, and we'll think it through.
May I ask a further, an additional to that is, so are the vehicles owned by the operators, or are the vehicles owned by other people? Does the operator lease the vehicles from a provider, or do the provider?
So TASL provide their own vehicles. Nationally, almost all operators, large-scale operators, provide their own vehicles. Usually they lease those vehicles rather than own them outright. TASL own a number of their vehicles. So, you know, different providers have different ways of working through their business model. There are very few where they contract out in volumes to third-party providers. That doesn't normally happen. Most providers either own or lease their own vehicles.
So I'm thinking about if you change provider, the new provider or providers, whoever they are, would have to obtain new vehicles from another source.
Yes.
Or, of course, TASL might decide to sell the vehicles they've got. If they've got no use for them, they might decide to sell them on. But then that means, of course, you have to have some time to consider the change of contract, don't you? That's what 2 years is about right.
Yes, absolutely. That's why I think I said that we want to make sure that there is sufficient time for mobilisation. One of the issues we had when we did the previous change from NSL to TASL was that there perhaps wasn't enough time to get all of the vehicles in place, and that caused a problem. So we want to learn from the mistakes that were perhaps made in the last procurement.
Because it's not just vehicles; it's drivers as well, isn't it?
It is. So drivers and crews are a little bit simpler because they would be subject to 2P arrangements. Right, okay, so there is a ready workforce there, and I think one of the issues about the procurement is what we don't want to do is devalue the work that the TASL crews do. My impression, having spoken to the crews, is they do a good job in very difficult circumstances, and we'd want to encourage those staff to continue with a new provider if we could do so.
Yes, I think that's right. I don't want to blame the staff at the bottom for the errors of, should we say, of the system. I won't go any further than that. But, you know, obviously, for patients in hospital waiting a discharge from hospital and being sitting there for 3 or 4 or 5, 6 hours, as it could be, I understand, that's not acceptable. So we have to have a system that works. And to have a system that works may mean that it might be better you have some competition between the providers. Otherwise, if you've got a one-man band, what do you do? I mean, we haven't been able to control anything of this, have we? I've sat in meetings before where people have complained about Tassel, and passed resolutions about it. We sort of have another 2 years with them, don't we? I think it's not a satisfactory situation for patients, and it's something we need to kind of plan in to how we could deal with a further situation should this arise. We need to have some, an exit strategy or something else which we can do so we don't have to sit out 5 years until the end.
I would agree with you. I think it's a point well made, and we will feed it into the procurement considerations. I think in terms of patients waiting for pickup at hospitals, I've been up at ULHT, I've been talking to patients up there, and I've got on the phone with Tassel and gone, you need to sort this now. So yes, well aware of the issues, and we don't want those to perpetuate for the next 2 years, not even for the next 2 months if we can avoid it, but certainly don't want to take that into a new contract.
Yeah. Thank you very much indeed, and thank you for all the work you're doing for us. Thank you very much. Thank you, Chairman. Thank you very much.
Councillor Woodley. Just conscious that we haven't got a lot of time or we're behind already, so if I can just ask for any future questions, if they can be formed in that form and not an ongoing conversation, that would be really helpful. Thank you. I've got 3 questions for you, Tim. Clearly, the CCG has had to prop up Tassel with the use of third-party providers, and this comes at an additional cost. I would imagine this was being recovered by imposing penalties for the failure of KPIs against Tassel. However, you've said that at the moment in time that can't be done. Can you explain to the committee, therefore, where the extra money is coming to cover this, and what level of money are we looking at?
I won't go into detail of the level of money, if that's okay, because I think that would be commercial in confidence. In terms of where the money is coming from, currently there is a route for the CCG and for providers to cover off additional costs associated with COVID. And that's one of the routes that we're using to provide this additional funding for transport, particularly for the Grantham Green site. The additional support that's been in at Lincoln County and Boston, that's been funded out of CCG resources. If we hadn't done that, I think we would have had a significant issue in terms of the flow of patients out of the hospitals. And that would mean that we've got more cost to the CCG anyway, because we wouldn't be getting patients discharged in a timely way. So it's a real balance and a real difficult balance. Again, I want to learn the lessons as we go into the next contract and make sure that we are confident that the funding that's provided into that contract will actually deliver the services and the KPIs that we want delivered. I don't know if that answers the question, but I prefer not to go into specifics about what we're paying individual providers, if that's okay.
Yeah, I can understand where you're coming from, but I think it's important for the committee to know that this is an additional cost, and obviously when you contracted this out, these were not fees you're expecting to pay on top.
That's correct.
Okay, I have another question. Can you please tell me if the KPIs that are in front of us within the papers are separated from those third parties that are now offering the additional support? And if not, can you separate these out to give us a clearer picture?
So the KPIs that you've got in the report are only for Tassel. We have different KPIs in the Grantham Green site contract, and we have different KPIs in the contract that is in place for the support to Lincoln County and Boston. That's largely because that's concentrated on discharges rather than patients going into hospital as well. The KPIs that you've got in the Tassel report include all the third parties and the subcontract work that Tassel have. So Tassel occasionally will contract out to a third party provider, and that's included in the KPI report that you've got in front of you.
Okay,
I don't know if that answers the question. Hopefully
it does. Yes, thank you. Finally, clearly the picture has seen little to no improvement for service users since awarding this contract to Tassel a little over 3 years ago now. I understand the CCG continues to offer regular support to Tassel to ensure improvement. However, things are not improving. In fact, they are as bad, if not worse. So what is the CCG doing differently now? And does the CCG accept some level of responsibility for what remains an unacceptable service to the residents of Lincolnshire?
So what we're doing differently is we're trying to work with TASL, and I think the committee knows that we've had a really difficult time with this contract over the last 3 years. I've spent an inordinate amount of time trying to improve this service, and there have been improvements, I think it's fair to say, but they're perhaps not reflected in the KPIs as they're reported. Certainly when I've been up to Lincoln County, spoken to patients, asked TASL to improve, we've seen improvement for a short time, and I think I've reported before what we're struggling with is getting TASL to keep that sustained improvement in place. We know that we are going to not extend this contract. We know that there is a deadline of June 22 for a new contract to be in place, and we know that there's a procurement. That, I think, is a strong lever for TASL to step up its game. If they want to be considered for the new contract, they need to make sure that they demonstrate to us that they are competent to deliver that new contract. In theory, according to procurement rules, when we go to the procurement, we shouldn't take account of our past knowledge of a provider. However, having learnt the lessons of this contract, we will frame the questions for the procurement to learn the lessons from the current contract that we've had and the current delivery from TASL. So that, I think, is our key lever now. I have regular contact with the Chief Executive of TASL. I talk to him probably once every couple of weeks and try and get the operational delivery, the day-to-day delivery, as good as it can be. Again, that's not reflected in the KPIs, but for individual patients, I'm often talking to the operational staff, escalating to the Chief Exec of TASL and saying, what more can you do to get this patient from point A to point B? And that takes quite a lot of work. So the CCG has stepped up, I think. COVID we'll ignore for a minute, but we have stepped up and we have put in place a number of processes to try and improve this. I think that is manifesting itself in the fact that we're not getting significant noise from hospitals at the moment, and we're not getting significant noise from patients. I would like to do some more work with Health Watch just to test that. But certainly, my understanding is that patients are receiving an acceptable level of service on a day-to-day basis. What we're not seeing is the contract KPIs being delivered. However, we will have to keep this under review. It can change, as we've seen with TASL, on almost a week-by-week basis. But that key lever is the threat of that procurement. Don't know if that helps or that answers the question.
It does. I think the problem is, in reality, is after 3 years of such poor performance, people have given up complaining, in total honesty. I think there is that element, and having spoken to Health Watch, yes, they were saying that they're not getting the same level of complaints, but no, that is my feeling, that people have given up simply complaining about this.
I think that's fair. I think that's a fair comment.
Thank you, Tim. I will now move to a proposal. Although that there are challenging circumstances currently in regards to the patient transport, I would like to once again record the committee's continuing concerns with the performance of Thames Ambulance Service, non-emergency transport service for Lincolnshire, but welcome the choice not to extend. I'd also like to urge Lincolnshire Clinical Commissioning Group to make every effort that the lessons learned from the existing contract are implemented as part of the procurement for the new contract due in 2022. And I'd also like to receive a further update in 6 months. Will I have a seconder for my proposal, please?
Yes, indeed you have, Jeremy.
Thank you, Councillor Brewis. In which case, I'd like to ask you all to switch your cameras on. All those in favour, can you please raise your hand? Have you got everyone, Trina?
Can I just ask if non-members can please switch their cameras off? Yep, we've got everybody. Yep, that's unanimous, Chairman.
That's unanimous. Thank you, and thank you, Tim, for the presentation.
And apologies again for the gremlins.
It's not a problem. It's modern technology for you. In which case, we'll move on to agenda item 7, the community pain management update. This is on pages 91 to 95 of the agenda pack. And I would like to hand over to our presenters, Tim Fowler, Assistant Director of Contract and Performance for Lincolnshire CCG, and Sarah Jane Mills, Chief Operating Officer for the West locality, the Lincolnshire Clinical Commissioning Group. I can hand over to you for about 10-15 minutes of the presentation, please, and then we'll take questions at the end. Thank you.
Good morning, everybody. I think Tim may just be relocating so that we can be in rooms together. And as if by magic, he walked through the door. Oh, you're on.
Yeah.
It's all right. We're just sorting the technical bit our end.
That's fine. If I can ask anyone who's not contributing at the moment in time to please switch the cameras off and to ensure they're on mute. Thank you.
Thank you. So today what we're doing is bringing an update on the report received in January 2020, and I'm sure it goes without saying, but just for completeness, obviously during that since that time we have also been responding to the COVID pandemic, and that has had an impact on the pain service. The current situation in terms of the community pain service is, as with other elective care services, it was required to pause for a period of time, and then services were slowly being reinstated. Just by way of a recap in terms of the service that was commissioned. The service that was commissioned is an end-to-end chronic pain management service, with Connect Health being responsible for the service throughout the pain pathway, from a GP referral through assessment and treatment to discharge. The service that's being conditioned is in line with best practice and is in compliant with the recommendations of both the Chronic Pain Management Service from the National Institute of Healthcare Excellence and the British Pain Society, and advocates that for a significant proportion of patients, we use a holistic biopsychosocial model of care rather than a medical-based model which required injections and medications. In terms of where we are at the current state, as I've explained, COVID presented a significant number of challenges for the pain management service, and generally Connect responded well, and there were a number of actions put in place during the COVID period to ensure that services were available. Some of those are continuing with regards to the virtual appointments, and as we reinstate other aspects of the service. Appointments for assessment and treatment were curtailed or cancelled during the very early days of the pandemic. However, working with the CCG, Connect were quickly able to put in place the virtual assessment appointments, and in May 2020 started to offer patients COVID compliant face-to-face physical appointments where that was deemed clinically necessary by a clinician, or where a patient specifically requested that they wish to attend. We appreciate that in some instances that has required patients to travel further, and that is due to the need for us to be assured that the access to the premises are COVID compliant. But the introduction of the virtual base of the service has in many instances reduced the need for patient travel. The most significant issue, and we're very mindful of this for a number of patients, is that the elective pain management treatment during COVID was largely cancelled, and that was in line with national guidance that did state all but essential elective care should be stopped and diverted the capacity to manage the COVID-19 patients. All patients that were cancelled during that period have been kept under the review, and the CCG have liaised on an ongoing basis to make sure that was happening. Connect have now restored all their services and are working to catch up on the backlog. You will note in the KPIs which we have included that there are under LQR5, which is service users starting treatment, there is a extended wait at this point in time whilst we catch up with that backlog. I want to reassure colleagues that that when we previously came in January, one of the issues in terms of access to treatment was about the clinical capacity. Since our meeting in January, Connect have recruited additional clinicians, so there is additional capacity, but the backlog we're facing at the moment is due to the fact that they are seeing patients who have had longer waiting times, and as they come off the waiting list, that will be reflected in performance. Early indicators are that performance will improve and continue to improve in September and going forward. Whilst the friends and family tests report very positive satisfaction, we are alert to the fact that there are feedback from patients with regards to some areas where there needs to be further improvement. Waiting times I've just referred to, expectations of treatments that have not been met, and specifically for those patients transferring from a hospital pain service to Connect. And that has included for a number of those individuals the fact that they haven't been able to continue their repeated injections. The work we are doing with Connect continues to look at those themes, and we are specifically working with them to make sure that their approach is person-centred and looks at the holistic needs for the individual, whilst obviously working in accordance with best practice. The other area is with regards to telephone consultations and the fact that a number of patients have fed back that they did not feel that they were of particular benefit, and we're doing more work to understand that. At the request, we have included the key performance indicators, and as I've highlighted, there is generally reasonable performance over a number of areas. But the two areas that we continue to work with Connect on are in relation to the initial appointment assessment within 40 days of the referral, although you will see there has been improvement between July and August, and the performance around patients starting treatment. I think I will pause there because I can see a number of people wanting to ask questions. Tim has joined me, so between us, hopefully we will be able to cover the issues that colleagues want to discuss.
Okay, thank you, Sarah Jane. Okay, my first question is from Councillor Whittington.
Hello, thank you, Mr. Chairman. Thanks, Sarah Jane. I have to express, even though I'm not currently a patient of Connect Health, I currently do have 2 prolapsed discs of my spine, which is causing stenosis, and putting pressure on my sciatic nerve. And as somebody who's quite often finds it very difficult to walk and not sleeping very well in intense pain, I actually find medication really helpful. And I'm due to have a further injection in a few weeks' time. And this comes back to me, I think, to the fundamental nature of this. I mean, I read the report and the phrase holistic biopsychosocial model of care. I have not got the faintest idea what that is. I understand medication and injections, and I understand that certainly for me, they have worked. They reduce the pain. When you're in absolute agony, they reduce the pain. How does a holistic biopsychosocial model of care do that? And I know it's based on best practice, but I'm just wondering if some of these people who devise best practice actually suffer from chronic pain. But that's another point. And then going on to the patient expectation, I can then see why patients are coming back saying their expectations of treatment haven't been met. Is that because they're still in pain? You know, if medications and injections were working, that may be why their expectations of treatment haven't been met. You know, it refers to the fact they've been upset because they've not been able to continue to have their injections. If they've been working, why have the injections been stopped? I mean, surely, you know, allowing. I mean, I find that when the pain's really bad, I have to use a walking stick, and I find trouble walking to the top of the road. You know, if medication injections work, why aren't they being used? And then I can see then why telephone consultations won't work, because if you've got chronic pain, it's no good talking to somebody about it. You want an injection, you want some medication that works. So I think that my questions, Sarah Jane, really go to the fundamental basis of why the model. Why have we moved? Because it's obvious from what patients are saying that they don't think their needs are being met. Thank you, Mr. Chairman. Thanks.
Thank you.
Thank you, Councillor Whittington. I think this is it is a very complicated issue, and I think there is no simple answer in terms of what meets the need of an individual person. What the recommendations of NICE and the British Pain Management Society highlight is that this is there are things in terms of everyday life and psychological support that can help individuals manage their pain. And the feedback we've had, and this is why it's a very complicated picture, is that for a significant proportion of people, actually that works exceptionally well. And learning exercises that can help them relieve that pain is, you know, for a significant proportion, does enable them to come off medication, which does have other consequences. So longevity of medication brings with it other consequences. Of course, that isn't the case for everybody, and this is the work that we do on an ongoing basis with colleagues in Connect to make sure that what we are alert to is that whilst we have best practice, we also need to be sensitive to the fact that for some individuals, their treatment will need medication or might need medication on an occasional basis. And it's that person-centred approach that is what we're trying to achieve through this service. And I think there is no simple answer. It is very much a relationship between the individual and their clinician and working through that. There are clearly, for patients who've been on medication for a very, very long period of time, you know, appropriate anxieties about what will happen if they don't have that medication. And again, that is one of the areas that we've worked on with Connect and continue to work on with Connect, about making sure that they are sensitive to that and perhaps are more flexible in terms of making that transition and working with the patient to bring about those changes.
Thank you, Sarah Jane. Thank you, Councillor
Thanks, Sarah
Whittle.
Jane. Thank you. Thank you.
Thank you. Okay, sorry, Dr. Wookie we have next.
Thank you, Chairman. Can you hear me?
Yes, I can hear you.
My question is relating to what Councillor Whittington has been raising, and I'd refer you back to the Health Scrutiny Committee in January 2020, when we also had a debate about a relatively small number of patients, but they are a significant number who are having the problems that have just been talked about. And we are still in Health Watch getting feedback from people who feel that the transfer has not been managed as well as it could be. I have no problem with in theory, with the advancements that are proposed by NICE, but these cannot take place on a single day and expect people who have been accustomed to different treatment to immediately switch over. You need at the very least a weaning period, and there may be some people who have been on therapy for some time who are going to need some special consideration and possibly stay on their existing treatment. What I thought we had been reassured on was that patients in this situation would have the opportunity for a full assessment by a consultant in pain management and to decide how best to go forward on a one-to-one basis. And I'm not sure that this is happening. It's not mentioned in your paper, although I realise you understand this group of patients are still there and still in need of help. So I think you've answered the question that I raised to some extent, but I don't think you have gone into the specific question of how management is going to be dealt with in a sympathetic way. By all means be holistic, but it does mean that some people do need some special consideration because of the problems they've had in the past. Thanks.
Thank you, Dr. Wookie. I couldn't agree with you more. This is very much about how we work with those individuals, and all those individuals should have and do have access to a consultant assessment, and that should be a partnership discussion in terms of what is right, because again, I couldn't agree with you more in terms of you can't just flick a switch, and there needs to be a transition period. And for some patients at the end of that period, the conclusion will be that they need to continue with that medication. From a CCG perspective, we continue to work with Connect to make sure that that service is available to patients, and that those patients that are transitioning or continue to be transitioning are receiving that level of support. We are aware of a number of individual cases that have either come to our attention from people like yourselves, or through feedback from patients directly to the CCG, where there hasn't always been what I would describe a person-centred approach to those. And in those instances, colleagues from the CCG are working alongside Connect to make sure that those individual issues are addressed for that individual. And we've got a number of those cases that are live. I don't know, Tim, if you want to add anything.
Yes, I think Sarah Jane's made the pertinent points. We do work really closely with Connect around individual patients. I had a conversation with Connect on Monday about 3 specific patients who had been on long-term medication injections, and we've agreed a plan of action for those 3 patients. I think one of the issues that we've had is that we've had some patients, and this point well made by Dr. Wookie, we've had patients who've been on continual injections every 12 weeks for 13, 14, 15 years. Changing that to a more best practice process, more best practice treatment, takes time and it takes sensitivity, and I fully understand that talking to patients about that is really difficult. I think Connect generally do that quite well. There have been examples of some patients, and Connect would accept this, there have been examples with some patients where perhaps that hasn't been done as well as it could have been. But I think it is the right way to go. The long-term disbenefits of having regular injections is well known. Nice point to it. That doesn't mean, as Sarah Jane said, that we would ever rule out giving injections and continuing with the treatment patients have had, but that needs to be done, as you say, with an assessment by a pain management consultant, and that is part of the process that's written into the service that Connect provide.
And I think just to add, and going back to, I think when we came in January, there was concern about the available capacity of those clinicians and those consultants. And again, since that time, Connect have recruited, and so there is increased capacity available to support those patients.
Thank you. So we can reassure patients who contact HealthWatch that they have guaranteed access to a pain consultant if they are in the problems that we're talking about, because I don't think it's just 2 or 3 people. I think it's quite a lot more.
Yes, Dr. Wookey, and I would be really happy to, receive feedback from yourselves, either Tim or myself, if, as you say, there appears to be a number of patients rather than individuals, so that we can talk directly to Connect and just make sure that there is no issue behind that in terms of particular clinicians or particular pathways that aren't quite working. So any feedback on that would be gratefully appreciated.
Thank you.
Okay, thank you. I've got one more speaker that has indicated they'd like to speak. Then I'd like to try and wrap it up ideally with a few questions I have, as I'm conscious of the time now, what with the issues with IT. I'll hand over to Councillor Sandra Harrison, please.
Thank you, Chairman. Good morning, Sarah Jane. I have to say I'm surprised that in your report to the committee you haven't actually mentioned the fact that those patients fortunate enough to be identified as requiring ejection, it's not mentioned that it's an entirely different company that is providing that, and named In Health, who have mobile theatres. And also there's nothing really to identify how many people actually have been identified and moved across to them. That area of the report just seems to be missing. And are the reports from In Health, are they featured in the KPIs as well? Thank you.
Thank you. In terms of the number of patients, I think we did provide that in previous reports, so apologies that we haven't included it again. We can certainly share that information. I'm going to ask Tim to just describe how the service works with regards to the injections.
So the service that we have in place with Connect is what we call an end-to-end service. So patients go into Connect on referral from their GP or transfer from another provider. Connect will do an assessment, they'll recommend treatment, they'll undertake that treatment. Where that treatment is an injection, what Connect will do is they have a route to put that out to a subcontracted provider, and In Health is one of those providers. There are others. In terms of In Health, they are a competent provider. We did some due diligence on them when we were setting up the service. They operate on a number of locations. They do a lot of work in the north of the county, and we are, as a CCG, we have no reason to think that they are doing anything that they shouldn't or any concerns with that contract. That due diligence happened when we let the contract to Connect. We keep talking to Connect regularly about whether InHealth are doing the right thing, what their impression of InHealth is. So in effect, we've got a lead provider arrangement in place where Connect are responsible for the injections, but they subcontract it out. That's no different to, for example, United Lincolnshire Hospitals contracting out some of its MRI capacity or some of its surgical capacity through to the BMI hospital in Lincoln. That's not unusual to happen. More than happy to include in the report and to send a supplementary through about the activity and the waiting times that are within health, and apologies again for not including that in the report when it first came to you.
Thank you very much. That will be very helpful. Thank you. Thank you, Chairman.
Thank you. Okay, I've got a few questions as well, please. Is there any progress by Connect Health in establishing sites on the East Coast for patients who cannot access the internet?
So during COVID, there was a scaling back of sites on the East Coast. Again, speaking with Connect on Monday, they are starting to reopen some of those sites and they are looking for new sites. One of the issues we had was that a lot of the sites they were using were in primary care practices, GP practices, and the GP practices during COVID limited the access to their premises. I understand that there are now 2 sites that Connect are currently actively exploring to restart on the East Coast. I won't say which those sites are, but let me just check with Connect that they're happy for that information to be provided to you, and we'll provide it as a supplementary.
Thank you, that would be helpful. I think you've alluded to this in part, Sarah Jane, but the report on page 93 of the agenda pack states that CCG is working with Connect Health, addressing a series of negative comments, such as long waiting times. Can you give any examples of what is being put in place by Connect Health, please?
So yes, we've had a lot of discussion with Connect about their long waits. They have recruited, as Sarah Jane has said, a number of additional staff, advanced practitioners and new consultants and a new GP with special interest. That will have an impact on these long waits. We regularly monitor the waiting times with Connect. And at the moment, for the latest information we've seen a significant reduction in the number of long waiters that has been supported by the additional staff that they have recruited. So I'm working from memory. I think when we were looking at this in June time, there were around 700 long waiters. We're now down to something like 300. So we are improving, and we expect that improvement to continue. Hopefully that will be back to more normal levels by the time we get to December. That's what we're aiming for at the moment. But there has been really good progress on that during September.
And I think, Councillor Macy, I think there are 2 issues here again, that we did have long waits as the service was being established. And Connect had a plan in terms of reducing that, which was the additional capacity, and then obviously that's been compounded by the challenges faced through COVID. The action plan that Tim's described suggests that will come back into line in December, but clearly that will be influenced by whatever happens with the wider COVID. And some of the associated, but not directly for Connect in terms of accessing facilities, because as you will be aware, primary care, as an example, have had to change some of their capacity to make sure that we've got facilities available to deal with COVID positive patients, and that has reduced that flexibility in practices. So we have a clear plan, but obviously I would put a caveat in terms of we will monitor that very closely given the context we're working in.
Okay, thank you. Okay, looking at the KPIs on page 95, the report highlights poor performance on KPI 4 and 5, and this is alluded to on page 93. However, what are the reasons behind this? And what is your action plan to improve this bleak picture?
So I think those are the issues that we've been referring to. So in terms of the initial assessment within 40 days of referral, that performance is improving, and that will be facilitated in terms of both the additional capacity and by using virtual appointments where that is appropriate for the individual. In terms of the treatment time, there is the combination in terms of the longer waiting times. So as those come through, the way that data is counted is it actually counts the number of weeks when a patient receives their treatment. So you will see a dip in performance as long waiters are treated, and that performance will improve as we get back into an 18-week performance. Both of those are linked to the action plan that Tim's referred to, and the target date of seeing significant improvement by December.
Okay, once again, thank you. On page 92, the report states that some patients were expected to travel further to face-to-face appointments during the height of the pandemic. Where were these patients treated, and what was there, if any, transport offered for those in need?
So we just had a session on patient transport. Where patients are eligible for patient transport will be provided. During the pandemic peak period, eligibility criteria was suspended, and therefore patients that needed to travel for their treatment, irrespective of whether they would previously have met an eligibility criteria or not, would have been transported by patient transport service. In terms of the numbers, I don't have that to hand, but again, we can provide that. In terms of numbers at locations, I don't have that to hand, nor do I have the exact locations to hand, but we're certainly happy to do that as a supplementary.
If you could do, please, I think it'd be very, very helpful for the committee to be aware. And then finally, is it possible for the committee to have sight the friends and family test result at all, please?
Yes, absolutely.
Yeah.
Thank you. In which case, I think I'm going to move to the proposals now, please. So I'd like to propose to urge Lincolnshire Clinical Commissioning Group to continue their work with Connect Health on reducing negative comments from patients, and to receive a further update in 6 months and sight of the friends and family test and the supplementary information as has been requested today. Do I have a seconder for that proposal, please?
Happy to second that, Chairman.
Thank you, Councillor Brewis, in which case I'd like to ask all members to now please switch on their cameras and raise their hands if they're in favour of the vote, please.
That's unanimous, Chairman.
Thank you, Trina. Thank you all very much, and thank you to our presenters. In which case, I'd now like to move on to agenda item 8, the Lakeside Healthcare at Stamford, on page 97 to 108 of the agenda pack. I propose to grant 3 requests to speak from members of the public, who we will hear with the first 3 minutes per speaker. The first speaker will be Mr. Andrew Nabel, Chair of the Lakeside Healthcare and Stamford Patient Participation Group. After the 3 minutes, I'll move on to our next speaker, and once all of you have spoken, I will ask for a response. Thank you.
Chair, this is Andrew Nebel. Thank you for giving me the opportunity to speak. I wonder if you can hear me, please.
I can hear you perfectly, thank you.
Thank you, sir, and thank you to the committee for allowing me the permission to address them. Thank you, Sarah Jane, for your report, which I've read with interest. A copy of my presentation is available to you after the meeting. As you know, Lakeside Group announced on the 16th of September that it would be closing St Mary's Surgery on the 1st of December. And we subsequently learned from Dr. Eames that 2 years' notice had been given for this closure in December 2018, thereby setting the clock ticking down to this closure over 2 years ago. Well, 2 years ago. This fact was never communicated to patients or the PPG committee, and it was only confirmed by Lakeside when the PPG told them that they'd learnt of it on the 26th of August. No substantive engagement occurred until 1 day before the public announcement on the 16th.
We know that in a public meeting in 2019, which was 6 months after serving notice to quit, a possible closure of St Mary's was mentioned in a public PPG meeting by Dr. Eames, but at the time he assured the meeting that no closure would happen without public consultation and the availability of a new building. It's not clear to us why this didn't happen, the consultation didn't happen, and we're not clear really why progress wasn't made to build and locate additional facilities. So the PPG felt patients have been severely disadvantaged by a lack of openness and a failure to communicate such a significant change in the practice's service delivery. And we feel the practice hasn't worked with the committee in the manner or spirit set out in the GMS contract under which it operates. Most of the engagement opportunities that have been provided are online, and this excludes patients without the means or competence to engage online, and also those who are being asked to respond by phone or post might be deterred from doing so for fear that they're not anonymous and they might be victimized. Our view, therefore, is that the consultation is an insufficient process to can be conducted in relation to such a significant change in service delivery. And we feel a full consultation process should have happened before the decision to close the surgery. We feel that by stating so emphatically in its communications that Lakeside had no opportunity but to close the surgery, any patient views about the continued use were effectively negated. Instead, feedback and questions could only be about the consequences of the closure and its impact upon provision of services at Sheep Market. Now, the PPG has not been given any demand or capacity modelling data, and I presume the CCG should have been, that gives assurance that access to delivery of care solely through Sheep Market surgery was feasible. We know from the paper Sarah Jane has submitted that the permission from the PCC, the Primary Care Commissioning Committee, has not been given, and that will be considered on the 11th of November, which is only 19 days before the announced closure date. And we've also had discussions with Health Watch, and they too have said they've not had any definitive notice of the closure. We're told that a statutory equality impact assessment...
Wrap up, please. You've gone over the 3 minutes. Thank you. I shall let you finish, Councillor Ebel, as long as you're quick, please. That's what I'm saying. Thank you.
I promise I misheard you. Okay, well, we're not sure if the statutory equality impact assessment has been done yet, and if it's being done after the event, then we question its relevance. So we believe it is possible to renegotiate an affordable extension to the lease of 3 to 4 years. That would enable the CCG, councils at county, district and local level, and North West Anglia Foundation Trust to lead a strategic view of the town and the surrounding villages' growing primary care needs, so that a fit-for-purpose facility can be created that would be part of an integrated care system. And we feel that's something that should be done. It's too important to leave it to the self-interest of a contractor. Thank you, Chairman.
Thank you, Mr Neal. In which case, I'd now like to hand over, please, to Councillor William Turner, Mayor of Stamford Town.
Hi, can you hear me now, Mr Chairman?
I can hear you, yes. So if you'd like to make your presentation, you have 3 minutes, please.
Thank you very much indeed. On the 29th of September, following the announcement by Lakeside of the closure of the St Mary's surgery, the item was put onto the agenda of the council meeting that evening, and a representative of Lakeside, one of the GP partners, Dr. Dan Petrie, attended the town council meeting. And he outlined the situation as follows: that the objective was for Lakeside to pursue opening a new medical centre in Stamford. However, this has not come to fruition and has led to Lakeside taking the decision to close St Mary's surgery from the 1st of December 2020. This has already been stated by Andrew, will mean that all the primary care facilities in Stamford will be moved to the Sheep Market surgery on Ryle Road. During the discussions that took place, the following points were raised. Should Lakeside have consulted with the Care Commissioning Group before announcing the closure of St Mary's Medical Centre to its patients by text? Why was not a quality impact assessment undertaken by Lakeside, especially as the Lincolnshire CCG's mission statement has a directive against health inequality? we know that it is Lakeside that have called in the break clause on the lease agreement to be implemented on St Mary's Medical Centre, despite the landlord offering no rent increases until 2025. There has been an increase in chronic illness, and GPs nationally seem to be directing patients towards more online consultations, which is very distressing when patients need to see a doctor face to face. Patients are entitled to a choice, and arguably the apparent monopoly of provision of healthcare by Lakeside in Stamford should be addressed. It was recognised that Lakeside's objective had always been to close St Mary's Medical Centre as the building was considered unfit for purpose. Would the current rental agreement for St Mary's Medical Centre be reconsidered in view of the landlords having offered no rental increase? It was believed that Lakeside were offered 2 plots of land on which to build a new medical centre, but these were not taken up. There is a real fear that the temporary closure of the minor...
30 seconds, Councillor Turner.
Sorry?
You have 30 seconds.
Oh, okay. It's just the fact that the telephone system takes about 45 minutes to negotiate to speak to anybody at the medical centre. There are no sufficient parking facilities at the Sheep Market surgery, and that space is shared with the hospital, which have a plan to remodel their car parking, which will seriously disrupt car parking while that is carried out. Thank you, Mr. Chair.
Thank you, Mr. Mayor. That's very helpful. Thank you. I have my final speaker now, which is Councillor Gloria Johnson from South Kesteven District Council and Deputy Mayor of Stamford Town. If you could come in now, please.
Yeah. All right. Good afternoon, everybody, and thank you for giving me this opportunity to speak. Listening to the other 2 speakers, they have covered a lot of the ground that I was going to cover, but I think I will go on the tack of being a patient of St Mary's. I've been a patient of St Mary's for 40 years. I've always been very happy with the service, always with everything that's gone on there, until they were took over by Lakeside. Lakeside has been nothing but abomination to Stamford. It has now got a total monopoly. I would like to see that another practice come to Stamford and let them have some proper competition. As Councillor Turner said, to get an appointment, you are at least, I've never been less than 45 minutes, and it's always been online, which is absolutely disgraceful. And they don't see you, you can't talk to them, they're always in a hurry, and it's absolutely disgraceful. But they get away with it. They came a few years ago and gave us a presentation before they came. They sold us all these promises and everything, and nothing, absolutely nothing came of what they promised. If they'd done what they said, it could have been probably wonderful. Now it's abysmal, absolutely abysmal, and they ought to be ashamed of themselves. They don't actually, they make the right noises, but I don't feel that they actually care about the residents of Stamford. And I think it's disgraceful. They've got the opportunity of the contract till 2025. And Dr. Kelly, who was my first doctor in Stamford, has given them assurances they should take that offer till they're ready to take on the patients of St Mary's. Well, thank you very much. I am very passionate about it, and I look forward to some comments. Thank you very much for giving me the time.
Thank you, Councillor Johnson. I'm going to introduce our speakers in a moment, and then what I would like you to do is, before you move into the presentation, if you can briefly touch upon what has been raised, because clearly I don't want to stifle the debate for members of this committee, but I would like to hear some form of answer if possible. So first of all, I'd like to welcome Adam Cox, Chief Operating Officer for Lakeside Healthcare, Andy Ricks, Chief Operating Officer for South West Locality of the Lincolnshire Clinical Commissioning Group, and Sarah Jane Mills, Chief Operating Officer for the West Locality of the Lincolnshire CCG also. After they have presented, I will then ask people to please mention if they'd like to speak in the box. I already have a number of speakers in the chat. Thank you.
Councillor Macy. I'm going to hand over first of all to my colleague Andy Ricks, who will be able to just update you on some work that is currently underway, and then perhaps invite Adam to add anything he might like to add. So, Andy.
Thanks, Sarah Jane. Clearly, I've listened with great interest to the comments made by Andrew Niebel and colleagues. The PPG have been in contact with the CCG and raised their concerns with us, and they raised those concerns very specifically at our annual public meeting and at our CCG governing body, and we have responded as fully as we've been able to at that point in time. But it's clear that our relationship with the PG needs to continue, and all residents of Stamford affected by this need to participate as fully as they are able in the consultation exercise. It is very clear to us that there is a great deal of angst around the proposed closure of St Mary's, and what I would like to convey to the committee is that the CCG, in concert with Lakeside, are having very extensive discussions with the landlords of St Mary's. We're working very hard to try and resolve the situation to enable St Mary's to stay open for the foreseeable future, to continue to provide primary medical services for Stamford, whilst all of the other issues that have been raised about provision of primary care in Stamford are addressed. Those discussions are very positive, very encouraging, but have not yet fully concluded, but it is something that we are working on every single day. So that's my initial statement. I just wonder if Adam wants to comment on any of the matters raised around demand and capacity modelling, equality impact assessment and so on, and I'm happy to come back in once Adam's had the opportunity to speak.
Thank you.
Thank you, Andy. I suppose, just to reiterate, as Andy said, we're working closely with the CCG to try and get a solution around staying in St Mary's, which has always been our preferred option. And we think we may be in a position to make positive strides forward, but we'll wait and see what happens over the coming days. I think in terms of some of the pieces that have been raised, I think context is always important in what we're doing in primary care. And I think we all are aware of the pressures that primary care are under over the last 4 or 5 years. Over the last 4 years, we've seen a 16% drop in the number of full-time equivalent partners in primary care. We've seen over 1,000 less qualified GPs working in primary care, and we've seen an 11% increase in registrations of patients over 75 years of age. Fundamentally as well, we've seen over 1,000 practices close, 1,300 practices in fact close over the 5 years between 2013 and 2018. And I think this is really a background as to what we're dealing with here. So I think when we talk about the state of primary care, this is not just a Lakeside issue, there's a broader national issue which I think we're all aware of. In terms of the move itself, I'm not going to go into any questions. There's been enough questions raised through our FAQs which are accessible via the website. However, I can't talk about the lease in any detail. What I would talk about is the work that we're doing to put right some of the issues that have been raised today. So I think I've acknowledged on numerous occasions our phone system is not up to standard, and we've started that work this week to correct that issue. Just as an aside, yesterday our average wait time for a call was 4.5 minutes. That was down from an average of 18 minutes the previous week. So we're starting to make inroads into how we're changing that, and that involves realigning staff to demand, but also increasing the number of phone lines that we have coming into the practice. We also know, and we'll be releasing data on a weekly basis just to show patients exactly the changes we're making and the impact of those changes. In terms of car parking, obviously it's Going to be an issue with NWAF building a new car park and breaking ground in November. However, we have modelled the car parking based on the amount of space available at St Mary's and the amount of space available at Sheep Market. Our staff will be moving off site and parking elsewhere, and that will essentially give us the same number of spaces as we've currently got across both sites. So there won't be any change in terms of the capacity of the car park that we've got currently for two sites when we move, if and when we move to one site. I think the final issue that was talked about, there was something around surgery capacity which has come up, and whether the building is suitable, and there was also the issue of a quality impact assessment. The equality impact assessment will be submitted to the PC3 in line with the application to close St Mary's, assuming that's the line we still take, depending on negotiations with landlords and CCG and ourselves. However, the surgery modelling that we've done, we've taken into account pre-COVID face-to-face appointments and COVID telephone volume, and there is enough space for us to run at 95% capacity at the Sheep Market site by moving all the patients. I think what is crucial to say here is we're not moving 15,000 patients from St Mary's. We're moving less than 7,000 patients, essentially 7,000 patients worth of demand, because the number of appointments that we delivered out of St Mary's was substantially less than that of Sheep Market going forward. So it isn't the closure of a 15,000 patient practice in terms of volume through the practice. The final thing to mention on the two buildings, without talking about lease, is that Sheep Market site is far more suitable for disability access than the St Mary's site. Now, there obviously is an issue of distance and travel, but on the whole, the site is all ground floor. The doors are wider, there's electric doors, and there's no thresholds for people to get through wheelchairs. Generally speaking, it's a more purpose-built building for primary care. I think that's everything I can update on now, Andy.
Thanks, Adam. So, Councillor Macy, if I just come back. Because I think the most important point for the committee to understand is the fact that all parties are in very active discussions to try and secure an agreement with St Mary's to so that is still available. Clearly, those discussions are literally live. I know they are happening as we're speaking and ongoing, and we will, of course, update people as soon as we possibly can in terms of the outcome of those discussions. The other point that perhaps would be helpful for the committee is, I know we have discussed that at a future meeting that actually we do a fuller presentation on primary care. And I think a number of the points that Adam has alluded to is perhaps some of the areas we can go to into more depth at that meeting. But clearly, from a clinical commissioning point of view, we are keen to continue the dialogue with groups and local stakeholders, and particularly the patient participation group, to make sure that as services develop, they are in line with patient need and population need, and that is something that we will be actively doing, and those discussions will take account of planned future changes in terms of local developments, which I know is of concern in this area. So I think just to reinforce active live discussions, which we believe in good faith will come to a positive conclusion, but obviously they are live as we speak, and we will update as soon as we possibly can. Councillor Macy.
Thank you, Sarah Jane. I think it's important for the committee to realise that although these very positive sounding discussions are taking place, we need to look at it as a committee as if this is still going to result in a closure, and therefore whatever we decide to move forwards with needs to be taken in that veil. So I'd now like to hand over to our speakers. Our first is Councillor Whittington.
Hello, yeah. Hello, thanks, Mr. Chair. Now, I'm not sure if there are any councillors from Stamford who are members of this committee or not, but I'm a Grantham councillor, so I'll get involved hopefully on behalf of the residents of Stamford. Heard some very powerful presentations by Councillor Johnson, Councillor Turner, and Ms Neagle as well, which would raise some very, very real issues for me. It seems to be there seems to be some real issue regarding notification of this entire process, and there does seem to be a real sort of lack of engagement and consultation with residents in Stamford regarding this. It seems to be that consultation seems to come for very, very, very late in the day. So I'd appreciate some sort of understanding as to why that's happened, and also the question about accessibility to the consultation process. If it's entirely online, I can't remember which of the speakers raised the point, but it does raise a very real issue that only those people with access to the internet can therefore take part in the consultation, which potentially is going to exclude quite a significant number, I would imagine, of quite elderly and vulnerable people. So I don't quite know how you can consult with the population and, by the nature of the method you're using for the consultation, effectively exclude a proportion of Stamford residents from the ability to partake in the consultation. I'm also concerned, I think an issue that Councillor Johnson raised in her presentation regarding the apparent monopoly that Lakeside seems to have in relation to primary care provision in Stamford. I'm a Conservative councillor. I'm a believer in the free market, but there comes a time when there are regulations around monopolies, and we wouldn't sort of like a situation where, for instance, there would be one major supermarket provider in Stamford, because there needs to be proper effective competition in order for things to work. So I'm really concerned about that, and just wondering what the CCG could do to potentially resolve this issue, to actually get some proper try and get some proper competition into the primary care market in Stamford. Well, I'm not sure as well as it's raised about if the proposal does happen and some areas is closed, that the capacity at the sheep market will then go up to 95% capacity. I'm very much aware that capacity in GP surgeries is often quite seasonal. Especially during the winter, you have more and more people who need to access primary care. There's colds, there's flu, there's winter falls, there's all kinds of issues relating to that. I'm just wondering, is this 95% capacity, is that an average across the year? Has any thought been given to any seasonal fluctuations in the capacity? And so therefore, in the winter, can you say that you can operate 95% capacity? Surely this is a purely demand-driven thing, and if patients are ringing their GPs, you've got to somehow see them. And having one less surgery means that the one surgery that is there potentially could operate way beyond that 95% capacity. And what is the safe level of operation in terms of capacity level? Is it safe to run a system pure at 95% capacity? There's not a great deal of flexibility in there if demand does surge. So I really would need some clarification and around that, so some reassurance that if you do get surges in demand, if sheep market is the only surgery, that it can actually be managed, because otherwise potentially you've got vulnerable people having to wait. I would guess the impact is on increased waiting times. And I'd be interested to know what the current wait time for somebody getting a face-to-face meeting, consultation with a GP currently is in Stamford, and is it likely to increase if these proposals go ahead? Because plucking figures out of the air, if the current wait time is a week, and as a result of this it goes up to 2 weeks, well, that's going to cause an awful lot of anxiety, an awful lot of pressure to residents of Stamford, and potentially is that likely to then increase, where those patients go? Would they access other services, at Stamford Hospital, or would they go to Peterborough? The demand here is going to be played out at some point in the system. I just wonder where that demand is likely to be played out. So those are a whole lot of questions. I hope I can get some reassurance about it, because at the moment this whole thing To me, it sounds as if this closure goes ahead, residents of Stamford are going to get a demonstratively worse service, worse primary care service than they're currently receiving. I think that's to be a matter of great concern for this committee. Thank you, Mr. Chairman.
Thank you, Councillor Whittington. I will try and steer. There was a lot in that, so I will try and steer our way through that. With regards to the issues you raise in terms of the consultation and the process, I think, as my colleague Andy has highlighted, we have had that feedback at both our annual meeting and at our recent board, and our focus is very much on working on a solution together and making sure that we work together with the practice, the freeholders and ourselves to find a resolution, and that we work with the PPG going forward to make sure that they are fully engaged as services develop. Andy, I don't know if you wanted to add anything to that specific point.
I think the issue of a monopoly provider is an interesting one, in that nationally we are seeing an increase in the presence of just one provider in towns particularly. That's because practices choose to merge to ensure they're sustainable and resilient. Adam's talked about the reduction in workforce and the demands faced by primary care, and GPs and their partners want to try and remain as resilient as possible. There isn't actually anything in the policy guidance manual, which is the sort of book that helps us to navigate our way through how services should be organised, that stops practices merging if they've gone through appropriate public consultation, which clearly happened in Stamford back in 2017 prior to that merger. And I think hindsight is always a wonderful thing, but it would seem to me, my impression, and others may not have the same view, that the angst about monopoly is linked to the view of the current quality of service delivery. And if those issues can be addressed and resolved, I think the monopoly question wouldn't be such a thorn in people's sides. But trying to find another provider, another GP practice to come into an area is in itself quite difficult. General practice receive their income based on the number of patients registered with them. So you would need to find somebody who is prepared to take a risk to find premises in the hope that once they opened, that people would come and sign up with them. And that's not particularly attractive to many organisations at all. So whilst it is in our minds, the issue of monopoly, I think that I would rather we worked with Lakeside to address the problems that are vexing people at this point in time.
Thank you, Andy. And again, Councillor Macy, I think a number of the points that Councillor Whittington raises, I think will be part of the presentation we do more widely about primary care. Increasingly, we are alert to the fragility of primary care, and certainly I have spoken previously at the committee of some of the challenges we've had in the West locality with some practices closing. And as we move forward as part of delivering stronger health services, what we will be working on is how we support primary care in their resilience, but also how we work in a much more integrated way, so that the model of services that people receive from general practice will change, and we will start to see people working closer together to deliver what I would describe as a more multidisciplinary service model, and that will include other professional groups, it will include other agencies, and this will be a big change for all of us. And again, I come back to the point, this is where us working with colleagues like the PPG will be absolutely vital in helping us shape that, but also helping us understand the local needs. And one of the things that has happened in the last year has been the establishment of primary care networks. And whilst that is different to the monopoly that colleagues are referring to in this context, I think it signals a direction of travel that GP practices, whether they are a large practice or smaller practices, will increasingly work together to make sure that we are able to meet the needs of the populations. So I wonder whether we might pay more attention to that when we talk about the primary care strategy and the wider direction of travel. In terms of some of the specifics around capacity and the modelling, I'm looking to Adam to help us just answer some of those questions for Councillor Whittington.
Thank you, Sarah. I think the capacity as an indication for you, the 95% capacity is at peak capacity. So essentially that is during the winter flu season period between October and February. So during the remainder of the year, we're looking at the practice operating at 85% capacity. In terms of the consultation process or the engagement process, I don't want to go into too much detail, and again, probably one for Sarah Jane and Andy to sort of talk about at the next committee if they talk more broadly about primary care. Whereas we would ideally like to carry out a consultation exercise, because of the issues around the lease, we weren't able to, and therefore we exercised an engagement exercise, which is in the General Medical Services contract that we operate. So we're following the correct guidance. It's not what we would choose to do. We'd choose to do more than that, but unfortunately, in the situation, we were forced down a different route. I don't know, Councillor Macy. I'm sorry, but I was asked to come on this relatively short notice, and I only had an hour between 12 and 1. I don't know if there's any more questions that anybody else wishes to ask before I have to leave the call.
We do have a number of speakers still, and we can only apologise. There was some technical issues. We do have to leave. Hopefully, obviously, Sarah Jane and Andy Ricks. I do want to ensure that this debate is had out in full, because it is incredible.
No, I completely agree, and obviously myself and the central team will pick up with Andy and Sarah Jane directly after the call and go through the issues that are raised, and we'll provide this committee with a full response to each question.
In which case, I'd like to move over to our next speaker, which is Councillor Whitton. Councillor Whitton.
Thank you, Chairman. I'm sorry I couldn't hear you because there was some noise going on in the background.
I think it was a snoring dog.
Chairman, this is disastrous for the people of Stamford. I'm sure that my colleague Councillor Whittington will join in with me that we stand with the people of Stamford, because this just sounds like deja vu with the closure of Grantham Hospital. No consultation, nobody's listening to our voice, and the people don't matter, and they can talk to the cows come home in Stamford, yet they seem to be going down this route of ignoring the people. I've had comments from campaign group members that unless you're technically savvy or you can have access to the internet, or any digital meetings, that your voice is not heard. I just want some reassurance that those voices are being heard. And also, can you tell me exactly, have you explained to the people of Stamford exactly what is the real reason for this proposed closure? Because they're concerned that you haven't exactly explained to them why it is closing. I'll just stop there, Chairman.
Thank you, Councillor Wootton. I think that I would want to say that we have very actively listened to the feedback, and for that reason the CCG, Lakeside and the freeholders are, as I've highlighted, working literally together to try and reach an agreement, which means that we don't find ourselves in this position, and actually what we can do is turn our attention to the wider issues about the longer term planning, and you know, we hope that those conversations will be concluded very quickly, and that we're acting in good faith that they will be positive, and that we'll be in a position to update people as soon as possible. But I would like to reassure you that all of the feedback has been received both by the PCC and the CCG in terms of that, and by colleagues at Lakeside, and that is why everybody is working together. The point you raise in terms of the challenges we find ourselves in terms of the consultation process, clearly we are operating in very unusual circumstances at this point in time, and we are increasingly, as with this meeting, having to rely on sort of like internet and virtual arrangements to get feedback, and you know, we that isn't obviously the optimum, and we're very confident that the presentations that we've heard today and presentations at our annual board meeting and our governing body are helping us to fully understand those issues, but take on board the challenges we face at this point in time in terms of being able to run a more traditional consultation exercise.
Yeah, thank you for that answer, Mr. Chairman. I thought that the Deputy Mayor Gloria Johnson spoke very eloquently on the issue that I think is most important, and that's the people of Stamford, the residents that you serve, we all serve, and I think, why can't the consultation be extended to get more people's views, particularly those who want to give views anonymously?
Thank you, Councillor Wootton. We will take that on board, obviously, when we do go to the proposals.
Thank you. Thank you, Chairman.
Okay, thank you. I have 4 speakers that have indicated they would like to ask questions. After that, I'm going to close down the debate and move to the proposal because we are very behind as of now. Therefore, I'd like to move to Councillor Thompson, please, with your question.
Thank you, Mr. Chairman. It's more observations on behalf of myself and Councillor Woolley. The Lakeside Health Care in Appendix C states that the PCC meeting on the 11th of November is to approve the closure application. The CCG update says that they require further assessment and the details of the engagements with patients, and it will be for the Primary Care Committee to review the evidence presented before determining the proposal. The patient survey is open at the moment, and it's open until the 25th of October. Whilst acknowledging the future provision of services from the St Mary's Medical Centre, for Lakeside, resting with the Primary Care Commissioning Committee and the CCG, Councillor Woolley and I hope that the Health Scrutiny Committee will wish to ensure that the primary objective of this is in the interest of the patients and residents, and that they are fully considered and fully supported. I would hope that the participants now would have some consideration for that. I'm aware that there are things going in the background, but it's against that comments made, approve the proposal rather than consider the proposal. And any comments would be welcome. Thank you.
Andy, I don't know if you'd like to comment.
Yeah, thank you, Councillor Thompson. I noted that myself in the documents. I think the wording to approve is unfortunate and clumsy language. The meeting of the Primary Care Commissioning Committee on Wednesday the 11th of November is to receive the request to close, and the committee will make a decision based on a number of factors, which clearly will include the equality impact assessment, the outcome of the consultation with public. As I mentioned earlier, we've had very clear representation from the PPG, APM and CCG board. Clearly we're at the committee today and hearing the concerns raised by others. But to approve signals an outcome that is reserved as a decision of the committee.
I think it would be very, very helpful for this committee if there was some change of wording then, because it is not helpful in this current circumstances.
Thank you, Councillor Macy. Andy and I will pick that up with Adam after the meeting.
Thank you. Okay, in which case I now have Brian Wookey. You'd like to come in.
Thank you, Chairman. I think the debate so far has clarified to some extent and confused to some extent. The situation as I understood it as a result of some discussions that Health Watchers had both with the PPG and with Lakeside over the last 2 weeks, was that the situation was not quite in what it is that the CCG have now reported. And in particular, I really would just like to clarify and ask the CCG to clarify as much as they are able, given that discussions are confidential and they may not be able to give great detail. But is the situation now that the proposal to close St Mary's may be off the table for a period of time while further investigation of alternative sites is resolved? If that is so, that is a potential game changer, but I appreciate that things are still under discussion, because one of the queries that certainly that we had was there was a question of just how serious the search for alternative premises had been, given the I think fairly obvious impression that the congestion at Sheep Market would be such that there would inevitably, virtual or otherwise increasing, be tremendous deterioration in patient care. The other queries that we had related to the situation geographically near Sheep Market and the hospital. For a small town to have the opportunity to have their GP surgery and their hospital on adjacent sites is a great prize if that can be achieved. And we have not been quite clear as to why some discussions that took place with North West Anglia have not come to any sort of fruition. To an outsider, two parts of the NHS talking about the same site and not coming to any conclusion. In fact, it may be, as we understand it, it may be too late, seems to be an opportunity lost. So I just think, can you please, CCG, tell us exactly where the situation is now and what are the alternative options besides everybody squeezing into Sheep Market?
I'm going to ask Andy if he would like to first respond.
Thanks, Sarah Jane, and thank you. I'll go back to sort of my opening statement, really, and Sarah Jane's reiterated this on 2 or 3 occasions about the active live discussions around the opportunity that is in front of us to retain the use of St Mary's. Those discussions are always ones that should be considered not over until they're over. But all I will say is I have a very high degree of confidence that we will come to an elegant solution about retaining St Mary's as a site for the provision of primary care. So very high indeed. With regard to NWAFT and the options to have all of our medical services on one site, which is stated is a prize indeed. We've been in discussion with NWAFT, South Cast Stephen District Council, for a considerable amount of time, and people will probably be aware that NWAFT opened up to the market to sell off parcels of land. Lakeside considered that carefully, but decided not to progress with any expression of interest due to a number of reasons, the archaeological issues that present on that land and other factors. And I think some of their thinking, and it's a shame that Adam has gone, was that they potentially could reconfigure Sheep Market and possibly extend it to build a bigger facility. But I also note that NWAFT at a recent meeting are talking about, as they remodel the Stamford Hospital site, about a primary medical service. And all I can say about that is there have been some discussions in the past, but those discussions are ongoing. And yes, we have looked at other sites around Stamford area, but unfortunately none of them have yet come to fruition. But I think one of the outcomes of the present situation is that we are going to have to step back and start to look again at all of the options available to us. It would be remiss of us if we didn't do that.
Thank you, Andy. And I apologise, Dr. Wookey, if we've confused the situation. I think, as Andy says, obviously what we're trying to do at the moment is find a solution so that patients can be assured in the short term that they've got the access that they need, and that creates the opportunity for that more considered future planning. The point you raise in terms of agency working together, I think we would all agree with you, and we consistently look at not only how we work with health colleagues, but also part of the wider, I think the term is one public estate, about how we use community assets to support not only health provision but also improved access. It's been a thing that we, an emphasis that we have had for a number of years, but increasingly as we move towards delivering much more integrated services, there is clearly greater opportunity for us to look at co-location and working together to actually strengthen access in community services. So just by way of reassurance, that is absolutely a focus of the work we're doing, not only in Stamford, but across the whole of the Lincolnshire community.
Thank you very much, Sarah Jane and Andy. Just to say, if you could keep us informed as to any progress that you feel you're in the position to
absolutely.
sort of way, that would be very helpful if you could perhaps speak with Sarah. Yeah.
Absolutely. As Andy and I have said, we're hopeful that the discussions will be concluded and in good faith, as Andy said, get to a satisfactory outcome for everybody. But we can never say it is until it is concluded. But as soon as we have the outcome, we will update the committee and yourselves via Sarah.
I do want to make sure sooner rather than later. I know it's an incredibly important debate we're having now, but we are well behind what with IT issues and so on. I've got two more speakers, Councillor Renshaw, followed by Councillor White.
Thank you, Chairman. My point is my disgust that in the frequently asked questions that the partners have put forward is they're admitting that the telephony system is not fit for purpose. So it just begs the question that the CCG need to take cognizance of this, that a proper communication system is essential for the well-being of the health of the patients. A lot of patients that are hanging on mobile phones, likely to run out of credit, and bearing in mind that when they telephone the surgery, they're probably often ill or often distressed, and this just exacerbates the situation. And so it's about time that the CCG took cognizance, and we'll have one good telephony system which cuts out a lot of the unnecessary and peripheral communication that goes alongside that, and gives a short, succinct instruction to the caller and in an efficient manner to identify what they need to do to progress their illness. And it's the same across Lincolnshire, and the patients have been shortchanged. So can I ask them to seriously take that on board? And good luck to the arm of the protesters that seem to have been shortchanged. Thank you.
Thank you, Councillor Renshaw, and absolutely the issues of telephony and wider digital access is a priority, particularly following the sort of like rapid changes that we've had to make as a result of COVID, and discouraging patients from actually attending the surgery, which I know has been a big change and has put systems under pressure. We are aware that some areas, those systems were already under pressure, but I think it has intensified the situation, and from a primary care perspective, that is one of our priorities. And also, as you've referenced, as we go forward, looking at how we can put more resilient systems in place as part of the wider development that directs people to the right place very quickly is one of the areas that we will be looking at.
Thanks, Sarah Jane. Councillor White.
Thank you.
Councillor White. We seem to have lost Councillor White. In which case, I just wanted to ask, in terms of the capacity and demand assessment, feedback, and the quality impact.
Page 97.
Oh, and hello, Councillor White. You've only just popped in. Do you want to restart again, because we didn't have you there at all?
Okay, thank you. Sorry. On page 97, it is stated that a Lakeside healthcare practice has nearly 32,000 patients and is the largest GP practice in Lincolnshire. You have evidently made great efforts to support the practice in either renewing the contract at St Mary's or finding other premises. The question I would like to ask, which I think has been articulated by other speakers, is it really feasible to provide an acceptable level of service for such a large number of patients from one site?
Sarah Jane, you're on silent.
Thank you. I think the challenge that you highlight, Councillor White, is some of the debate we will need to have as part of our wider primary care strategy. And there is no simple answer to that question, because a lot of it depends on the local circumstances and the context. And across Lincolnshire, we will need to take due regard for issues such as health inequalities and how access to practices might impact on that. In a very highly populated area where people live close and all the rest of it, it may well be appropriate to deliver it from one site. In another area, that won't be appropriate. And in all of the circumstances, the Primary Care Commission Committee will need to consider that and look at making sure that the needs of the local population are met. Increasingly, the model of primary care will see patients accessing primary care, as I've identified, not just through their GP practice, but maybe using increasingly digital platforms, which for a number of patients are working exceptionally well. We are aware that for some patients they present challenges, and we're working to gather that feedback. But also where we work closely with other partners and we see increasingly provision, for example, therapy, we may well find that those services are provided from other locations. So I think there is no simple answer, because it is about the context, and from a clinical commissioning perspective, our focus will be making sure that the needs of the patients are met, and that what we don't do is increase health inequalities in supporting delivery models that don't reflect those local population needs. So that's quite a complicated response, but I think those are the sort of issues that we will need to take account of across our wider Lincolnshire community, and clearly are relevant from the feedback we've had from the residents and the PPG in Stamford.
Building on from what Councillor White has had to say, though, you know, you only have to look back to 2018, and initially you were contacted by Lakeside with them wanting to locate an alternative site in Stamford, which to me would clearly state that they needed two separate entities to be working on, because they've always had the other site there. Therefore, I think that's where the argument does fall flat. How you can change in that period of time to say now one is adequate, I do not see.
And I think that what I would go back to is that the CCG and colleagues are really working very hard to make sure that we can address the current issue, which will give us the time to actually develop that longer term solution, which takes account specifically of the developments in Stamford.
Thank you, Sarah Jane. Quite clearly, I don't feel that the committee or the residents, to be fair, have seen enough information to decide whether or not this is the right move. I haven't seen anything in regards to the capacity and demand assessment, the patient feedback, the equality impact. Therefore, would it be possible for this committee to see that information, please?
So I'm looking at Andy. That information I think will be pulled together as part of the presentation to the Primary Care Committee for them to consider, and as that is available, obviously we will share that. In terms of today, the primary focus from our perspective is working on the agreement, and critically, Councillor Macy, Andy and I would like to be in a position where we can feedback on that with what we hope is a very positive outcome, and will give us the time to have the longer term discussions, which I think this has highlighted are really important.
Thank you, Sarah Jane, in which case I'm going to move to the proposal. I think it is beyond disappointing in the way that there has been a lack of consultation and engagement with the residents and patients at these surgeries at the moment in time. And although I understand you have live active discussions that are taking place and we can note that, I think it's important that I, as the chairman, am authorised by this committee to write to the Lakeside Healthcare, recording the committee's opposition to the proposal to close St Mary's Medical Centre, to request the quality impact, capacity and demand assessment and patient feedback, and that I, as chairman, be authorised to write to the chairman of the Lincolnshire Clinical Commissioning Group's Primary Care Commissioning Committee, urging that full account is taken of the views of the Stamford residents when it makes a decision on the proposed closure of St Mary's Medical Centre.
Yes, yes.
Do I have a seconder for my proposal, please?
I'm very happy to second that, Chairman, yes.
Thank you, Councillor Brewis. In which case, I'd like to move to the vote, please. Can you all switch on your cameras and raise your hands if you're in favour of the proposals? Those who are not members of the committee, please can you switch your camera off for the time being?
That's unanimous, Chairman.
Thank you, and thank you to our presenters for today. Okay, in which case I'd like to move straight on to agenda item 9. I will try and keep this as tight as possible to try and move things on, because I'm sure that you'll all be desperate to move on. We've got agenda item 9, Vale Medical Group, pages 109 to 118 of the agenda pack. I have presenters Claire Raybould, Chief Operating Officer, the South locality of Lincolnshire Clinical Commissioning Group, Shona Brewster, Head of Transformation and Delivery, the South West locality, and Sarah Jane Mills, Chief Operating Officer. Sarah Jane, if I can ask you to try and keep it to no more than 10 minutes, please, if possible.
Thank you, Councillor Macier, and to facilitate that, I am going to hand over straight away to my colleague Claire, who will be able to present the issues for you.
Thank you.
Thank you, Sarah Jane and Councillor Macy. So just to give you a bit of context, Stackyard Surgery is situated in Leicestershire, very close to the Lincolnshire border, and is part of the Vale Medical Group, along with Long Clawson Surgery, which is part of East Leicestershire and Rutland CCG. Woolsthorpe is a branch of that surgery that sits within the Lincolnshire border. The practice has 3,730 patients from the Leicestershire and the Lincolnshire area. Since the summer of 2019, the practice has been part of a primary care network called Syston, Vale and Melton within the East Leicestershire and Rutland Clinical Commissioning Group. You will be aware that any practice wanting to make any significant changes has to apply to the CCG to do so and undertake engagement and/or consultation as advised by us, depending on the change. As Stackyard Surgery would like to consider a proposal to close their branch surgery at Woolsthorpe, then we have advised them that they need to undertake a period of consultation, and they started that on the 11th of September and it runs until the 27th of October. You can see from your paper the rationale that the practice have given in terms of why they want to close that surgery, and given the time today I won't rehearse some of that for you, but there are clearly issues with the type of surgery that is at Woolsthorpe, and also the evolving nature of the change in general practice over recent years. As part of the consultation, they have sought views and they've written to all of their patients, as you've seen, and stakeholders have been invited to feedback. That includes parish councils, MPs, neighbouring GP practices, pharmacies, and obviously yourselves. We've had just short of 120 completed surveys, and we've had a range of feedback either direct to the practice or already to the CCG from parish councils and independent people already, and a mixture of feedback in terms of positive and negative at the moment at this stage. I attended one of their consultation events. They had some really good feedback at those about what would help, so particularly things like medication reviews and being able to take their medication in a bit of a pop-up shop in Woolsthorpe Village, a bit like the post office does and the butcher and everybody else, as I understood from members of the public on that meeting. So they are actively listening to the feedback, so I can assure the committee of that. Once the consultation ends on the 27th of October, then the Vale Group will have to undertake an analysis and produce a report to the CCG. That report will then go to our Primary Care Commissioning Committee, and they will meet in public to decide on the analysis that the practice has put forward in relation to their proposal to close that branch. It'll be fully considered by the committee. We will look at all feedback we've had directly to the CCG and also to the practice, and we're really clear with them that they need to put in actions and mitigations against some of the concerns that will have been raised through their period of engagement and consultation. It's likely that that will be seen and heard at the public committee in either December or January. The next meeting of the committee is the 11th of November, and there isn't sufficient time for the papers to be prepared for that meeting in November. So just to make you aware of the time frames, I think your paper reference is potentially November. There are two proposals in their consultation. So one is the closure of the surgery and the branch surgery, and one is an administrative move to East Leicestershire and Rutland CCG as a practice in its entirety. The CCG, the Lincolnshire CCG, does have the authority to make the decision on whether the branch closes or not. That certainly rests with the Primary Care Committee. The actual decision on a practice moving in or out of any CCG's boundary is a decision for the incoming CCG. So East Leicestershire and Rutland CCG will decide whether they accept the practice. Lincolnshire CCG doesn't have a decision in relation to that. The only decision we have to make is the amount of funds that go with that move. Even if that was agreed by East Leicestershire and Rutland CCG, it couldn't take place until April 2022 anyway, because there are certain stages in the process that have to be gone through in terms of application to change any CCG constitution. So, but the practice wanted to be open and transparent that is something that they wish to do, and are starting to have those conversations. So that's all I will say, but happy to take any questions.
Simon Evans, you wanted to come in, you've raised your hand. Simon?
Sorry, Chairman, that was a mistake, raising my hand. I have no questions or nothing to add at the moment.
Okay, thank you, no problem. Thank you for the presentation, in which case I'll go over to our first question. Councillor Whittington.
Thank you very much, Mr. Chairman. The Woolsthorpe surgery is within my division. So obviously I'm very much concerned about the proposed closure of the Woolsthorpe surgery. I have attended at the last meeting of the Woolsthorpe Parish Council, which I attended. Considerable concerns were raised by the Parish Council relating to a whole variety of issues, some of which I will share with you now. They have been approached by quite a number of residents of Woolsthorpe. A lot of quite elderly, vulnerable people live in Woolsthorpe. They don't necessarily have access to cars. And having the surgery in the village meant it's very easy for them to access it. There's no direct public transport connections from Woolsthorpe into the proposed into the other sites. So I'm aware also of one particular instance where a lady had to walk from Woolsthorpe to Crowston, which is quite some distance, because she had no car, there was no public transport available. I think, Mr. Chair, this is a completely unacceptable situation. I'm also aware that a number of residents in Woolsthorpe who are members of the practice are looking to try to register with GP practices in Grantham, because there is a bus service, albeit a very limited bus service, from Woolsthorpe into Grantham. And I'm just wondering if, for any patient potentially, that's still a considerable distance to travel. With a bus service, I think there's one or two buses a day, but it's not a great service. So potentially, if they do want to change to a GP practice in Grantham, they'll be limited as to the sort of appointments they'd be able to access because of the limitations of public transport. So I want some assurance that and we've also discovered, as made clear in the discussion over patient transport. Patient transport doesn't cover patients attending GP appointments. Other concerns that were raised is that not all CCGs fund the same the same procedures and the same medications. I mean, we're obviously aware, you hear the stories about one CCG funds one particular type of cancer drug, but another one doesn't. So a lot of concerns have been raised about it. If patients are currently receiving a particular type of procedure or medication that is currently part of the contract that Lincolnshire CCG has, will that still be, is there a guarantee that that will be provided by Leicestershire CCG if it's not within their contracts or stuff they purchase? There's a lot of doubt about that. There's also big issues around referral patterns and direction of referrals as well, because at the moment the first port of call for people in Woolthorpe who need to access secondary care would be into Grantham, and then potentially to Lincoln and wherever, but at least there is public transport available. A lot of concerns about if they're going to Leicestershire, those referral patterns may be shifted more towards Leicester, which again is for people without access to cars in Woolthorpe, it's completely inaccessible. In terms of things we discussed about the St Mary's practice, I've seen no capacity modelling around this. Are the other two sites of the Vale Medical Group able to deal with the capacity that's going on? I've not seen any quality impact assessment statements being provided. I've not seen anything around health inequalities. Mr. Chairman, this is just, and for the residents of Woolthorpe to be given 8 weeks to respond to this, it's quite frankly shameful. It really is indeed. Information just not available. It's similar issues to the ones we've just discussed with regard to Lakeside. Now, obviously, a lot of people have made a lot of with a pretty hefty discussion around Lakeside. The issues here are the same, and as I say, I may be the only person who will articulate those concerns, but I'm articulating them on behalf of the residents of Woolthorpe, my residents, people I represent who have real concerns about this and the manner which this has taken place. They were assured in 2017 when Woolthorpe practice merged and became part of the Vale Medical Group that there were no plans. There were no plans to close Woolthorpe surgery. Woolthorpe surgery would be fine. Obviously, COVID's come along, and I just get the impression from this that the COVID is being used as a convenient vehicle to do something that the Vale Medical Group have always wanted to do. Mr. Chairman, I have to say I'm extremely disappointed with this. I think it's obvious and apparent from some of the comments that I'm actually making, and I would like the recommendations from the previous motion regarding Lakeside to be for similar recommendations and actions on behalf of this committee with regard to the proposed closure of the Vale as well. It doesn't affect as many patients, obviously, as the Lakeside and Stamford, but the impact on each individual patient will be the same. So, Mr. Chairman, I would like the support of the committee. I would like my questions answered by Sarah, Jane, and by Claire. I'm not happy. Residents of Woolthorpe aren't happy. The parish council aren't happy. And in terms of key stakeholders, the parish council found out extremely late about this process. I'm the county councillor. I received no notification about the procedure. About it. They claim key stakeholders have been contacted. Mr. Chairman, I'm challenging that. I would just like some answers to some questions. Thank you.
Thank you, Councillor Whittington. I gave you a bit longer because I know that you are the ward member. So any further speakers, if you can keep it a little bit more short, please, that'd be helpful. I'll hand over to Sarah, Jane and Claire for the response, please.
Thank you, Councillor Macy. I'm afraid I had a bit of technical problem, so I missed the middle of that. So I am going to just hand straight over to Claire, who hopefully will be able to address all the issues.
Thank you, Councillor Whittington. I'll try and recall most of what you talked about. So if I just start in the reverse order. So in terms of the plans around 2017, you're right that they did say there were no plans, and I actually believe they haven't had any plans. The surgery invested quite a bit of money into Woolsthorpe earlier this year. In terms of some recarpeting and other things. I don't think the carpets have actually even been walked on because of COVID. So I genuinely don't think that this was an intention. That said, in terms of their equality impact assessment, that is being undertaken at the moment and will be part of the pack that is presented to the Primary Care Commissioning Committee. They have done quite a lot of work on capacity, and they shared that quite openly as a presentation at the public meetings that they did, and I think they have put it on their website, although I can check that. So they were able to articulate how they're operating at the moment, and as you all know, the majority of general practice is a kind of triage screening first, but then if people need to be seen face to face, then they do so. They are still doing home visits and will continue to do that into the Woolsthorpe area, so that doesn't stop. In terms of the patients that visit Woolsthorpe, they do come from quite a wide area. In fact, actually quite a big proportion of the catchment comes from Grantham. I think it's people that probably grew up in the village and have moved but have remained at that surgery. So it's not unreasonable that some of those might want to go to Grantham, and in fact a couple of members of the public did say that they may do that. And there is capacity in some of those surgeries in the town. They've had recent investment in terms of being able to grow their list sizes. So in terms of the capacity at Stackyard, that was answered in quite a lot of detail on the public events. So they, again, with the change in the way general practice works at the moment, and the people that really do need to be seen face to face being a lot smaller than it used to be before, and will continue post-COVID. Many practices have been operating like that for about a year, but COVID has forced that new technology upon general practice across the country. So they have got the capacity. You're quite right around access. Clearly, you know, it's 3 miles from Woolsthorpe to Crowston Kerrial, and there isn't a bus. So yes, for some patients that is a difficulty. But again, I think the practice were able to articulate some areas of mitigation that they were looking to put in place, and certainly were given some good suggestions on the events I attended that they were going to go away and scope, and we will expect to see that in the analysis that they provide to the CCG. In terms of patient procedures and referrals, that's been raised quite a lot by members of the public so far in the feedback, and I spoke at both events that you if you're currently undergoing a pathway of treatment and your practice moves CCG, it doesn't make any difference. You will still continue on that pathway with whatever provider. You can be referred wherever. Your GP can do that for consultant-led care. So if you're currently going to Grantham, you can still go to Grantham. If you're currently going to Nottingham, you can still go to Nottingham. So there's no change there. In terms of community services, East Leicestershire and Rutland CCG do commission a bit more from primary care practices than we do in Lincolnshire in actual fact, so that definitely wouldn't be less. It would probably be a little bit more, and certainly some areas that we may look at as well. So there's no impact on where you can go. So some people said, if I was picked up by an ambulance, where does that mean I will go? You will go to the nearest accident and emergency department. It doesn't matter which practice you're registered with, and which CCG boundary that you're in. But as I said before, in terms of the CCG, that's not a decision we can take. It is a decision of East Leicestershire and Rutland CCG, and a right that practices have to be members of a CCG, so long as it makes logical sense. And to be honest, this is one that was debated quite a lot when CCGs were formed about whether this practice was a Lincolnshire or a Leicestershire practice. It actually has more patients that live in Leicestershire than Lincolnshire, but I accept that for the patients of Woolsthorpe themselves that do live in Lincolnshire, that that's not easy. So we will consider all of those points at our Primary Care Commissioning Committee, and we will expect to see what the practice is going to do around those. So I think I've covered everything other than just about stakeholders. So I have seen evidence of letters that have gone to stakeholders. So I'm surprised at that people haven't got them. But and if anybody, Councillor Whittington, if you haven't and you should have done, then I apologise on behalf of the practice, and we'll pick that up with them.
Thank you.
Thank you, Claire. Can I just ask a point of clarification, Mr. Chairman?
Yeah, very quickly, please.
Very brief. You said the patients currently on a care pathway will be able to follow that care pathway. So if they've been referred to Nottingham or Grantham, they'll still go there. What about future patients? Because potentially people may be used that if they've got an issue, it goes to Grantham or it goes to Lincoln, and it's a lot easier to access those places than if it goes to Leicester. So it says for future patients. So is there any reassurance about the pathways for future patients? Thank you.
Yes, certainly. So my response, sorry, I wasn't really clear, is actually for current and future. So if you are being referred for consultant-led care, and there's very few exceptions, so whether it's 2-week wait emergency, there are exceptions, or if you are in an ambulance, you don't generally get given a choice about where you go. But for the majority of consultant-led referrals, you have a choice where you go. So if you've always gone to Nottingham, they can't say, no, you can't go to Nottingham anymore, you'll go to Leicester. And Leicestershire CCG is in the same region as we are, so they work closely with us. I work closely with my colleagues over there. So from that perspective, there should be no issues, because it's actually a statutory right that patients have to be referred under the NHS Constitution.
Thank you, Claire. Thank you.
Thank you, Councillor Whittington. I've got Councillor Wootton, and I'm going to close down the debate.
Yeah, thank you, Chairman. I'd just like to refer back to Councillor Whittington's proposal. I'd like to second that proposal. Claire, you know the area. Woolsthorpe by Beaver is in the middle of nowhere, with hardly any transport, and people do need the service. It seems to me as though all around Lincolnshire, everything's been centralised and the people are being forgotten. That's it, Chairman.
Thank you.
Thank you.
I don't think there was formally a proposal made, Councillor Whittington, though I would be willing to take on board your comments and put a proposal together now, if that's satisfactory to you, Councillor Whittington.
Yes, thank you, Mr. Chairman. If it could be worded in similar vein to the one you did,
it will be indeed
for Lakeside. I'm happy. I would like to propose that as a motion. Thank you.
Okay, I'll put my proposal forwards, and then if you're wanting to propose it, that's absolutely fine. So I would request that we get to see it, the capacity modelling, the equality impact, and the patient feedback, as we'd asked for in the last item. And also that the chairman be authorised to write to the Vale Medical Group recording the committee's opposition on its proposals to close the Woolthorpe branch. Also that me as chairman would be authorised to write to the chairman of the Clinical Commissioning Group's Primary Care Commissioning Committee, urging that full account is taken of the views of the Woolsthorpe residents when it makes a decision on the proposed closure of the Woolsthorpe branch surgery. Councillor Whittington, you happy with that, and you're willing to make that as a proposal, are you?
Thank you, Mr. Chairman. I'm very happy with that, and I would like to propose that. Thank you.
Thank you, Councillor Whittington.
I'm happy to second that.
It's been proposed by Councillor Wootton. Thank you, Councillor Brewis. So we've had it proposed and seconded. All those in favour, please show. So please switch your camera on. Thank you. I believe that's been supported unanimously, Trina.
Yeah, that's everyone, Chairman.
Okay, thank you to our presenters on that item.
And thanks, everybody. Thank you.
Thank you. In which case, we'll now move on to agenda item 10, the Louth and Skegness Urgent Treatment Centres. I know Simon wants to make a presentation on this initially, and then I just want to come after.
Thank you, Chairman. Very briefly, this flags up the consultation being undertaken on the proposed extension of the overnight closures the closures between 10 p.m. and 8 a.m. of the Louth and Skegness Urgent Treatment Centres. So this will be considered by the committee as part of the integrated urgent care item at the committee's next meeting. But the purpose on this agenda is to flag it up, and also as a means of publicising the patient survey which is taking place it looks as though it's, given the comments this morning about online surveys, it is an online survey, but I will check if it is also available in other formats. But that is my presentation. I think actually one more thing. I wonder if we could suggest that the county councillors in the Louth and Skegness areas are encouraged to publicise this in their local communities and parish councils. Thank you, Chairman.
Yes, thank you, Simon. I know that this is actually a motion went on the town council's website in Skegness around this issue, and it's very impassioned in this area. I have very serious concerns in regards to this continuing closure. It's been suggested that caravan sites along the East Coast will remain open over the winter period, which will put additional pressure on our local hospital with higher levels of visitors than what would typically have been seen in the off-peak season. I'm sure that this is attenuated by the fact that in both Skegness and Louth, residents and visitors are attending UTCs, as it's easier than trying to get a GP appointment currently. The additional problem is that the next nearest hospital to Skegness is Pilgrim, some 45 minutes away, and for Louth, the next is Grimsby. So I think it's important we do take a strong view on this. You also need to take into account that this committee pushed for 24/7 walk-in access to both Skegness and Louth UTCs in response to the Healthy Conversation engagement. And I do find that with this and the previous items, at least the last two, that COVID is being used as an excuse, I'm afraid, to erode services, and that's not something that the committee would agree with. Okay, I've got Councillor Whittington. You want to come in quickly, and then Councillor Wootton.
Yeah, absolutely. Thank you, Mr. Chairman. I mean, I completely support your comments about it. I think it's really important that it doesn't matter where services are, whether they're Grantham or Stamford or Vale or Louth and Horncastle. We have to stand together, in Lincolnshire to actually say that services are being eroded. Quite a lot of the items today have been about services being eroded or services not being provided properly. And quite frankly, this is extremely alarming. You know, we have to speak on the behalf of the residents of the whole of Lincolnshire to express our concerns, about this. And I think that we do need to make really, really strong representation that the proper 24/7 walk-in does need to be restored. And actually, I would really echo your comments on that, Mr. Chairman, that this committee should take a really firm stance on this. Thank you.
Thank you, Councillor Whittington, and thank you for your support. I've got Councillor Wootton next, please.
Yes, thank you, Chairman. I fully support Councillor Whittington's comments. You look at Grantham this morning on the graph showing how increased the number of people attending UTC were since over the A&E. It's vital that local people have local services open 24/7. So I will fully support you on that one. Thank you, Chairman.
Thank you, Councillor Wootton. I now have Councillor Woodliffe.
Oh, my dear. You can hear me. Oh, you can see me as well. Thank you, Chairman. I fully support what you said and what Councillor Whittingham said and Councillor Wootton has said. I think it's outrageous to consider shutting this essential service down at night. What's going to happen in the holiday season when you've got 250,000 people, occupying the coastline of Skegness onwards? I mean, to expect them to go to the Pilgrim Hospital as an example of it, which we all know is a good 40 minutes drive away on a good day. And if it's pouring with rain, well, it's another matter, isn't it? I mean, that A52 is a very dangerous road. So, I mean, I think it's not acceptable just to close off this essential service at night, between 10 p.m. and 8 a.m. and say, well, if you've got a problem, you can go down to the Pilgrim. Well, it's nonsense. And I think it's quite outrageous that this particular service should just be withdrawn like that. Skegness is a major holiday destination for the entire country. Large numbers of people come to Skegness and stay in caravans and guest houses and all the rest of it. And they need to have that service at night. If somebody needs to go and seek medical help, then it should be available. Not just 8 a.m. in the morning to 10 at night. That's not good enough. So I fully support what you said what Councillor Wootton has said and what Councillor Whittington has said. We've got to stand up for this, haven't we? Thank you very much.
Thank you, Councillor Wood. Thank you. Okay, I've got Councillor Brewis.
Thank you, Chairman. Mine's very brief, actually. I think Councillor Wood has said a lot of what I was going to say, but I think also when we see, and we all read in the paper about the shortage of medical personnel, what we've got to ensure is that the services across Lincolnshire, and this is evidence of it, are so attractive that we want to attract medical staff here, because the tsunami of the lack of medical staff hasn't quite hit us yet, and I think we've got some very difficult times coming ahead. Thank you, Chairman.
Thank you, Councillor Brewis, in which case I'd like to make a proposal that we make arrangements at the committee's next meeting on the 11th of November for responding to the patient survey by Lincolnshire Community Health Service NHS Trust on an extension of the temporary closure of Louth and Skegness treatment centre between 10 PM and 8 AM until 31st of March 2021, and to urge the Lincolnshire Community Health Services NHS Trust to make every effort to publicise the patient survey so that many residents as possible in Louth and Skegness and the surrounding areas can respond. Councillor Harrison, I can see you waving your hand.
Yes, Chairman, sorry, I wanted to make a contribution and you obviously missed my request. The system didn't work. Would I be able to add anything now?
Yes, certainly, we'll consider it.
Right, thank you. Well, I do feel strongly that anybody asking to respond to the consultation should really have some facts and figures presented with it. For instance, comparison prior to the closure and how many patients during the closure that 111 had to deal with, because there was no availability of services at Louth and Skegness. But also, if I might suggest, to increase the response, that the consultation is also sent out to the community groups in those areas, which the Resilience Forum will have composed during the COVID time. They have the contact details. They could perhaps circulate it and ask it to be moved on into the community by those groups, because it is potentially very, very important, and as many people as possible should be able to respond in an informed way, not just a passed on comment from neighbours or whatever. It's important that it's got right.
Yeah, we'll certainly take that on board and make that request also as part of my proposal.
Thank you very much.
I've made the proposal. Have I a seconder, please?
Yes.
Thank you, Councillor Brewis. In which case, if you could all switch your cameras on, please. All those in favour, please raise your hand. Thank you. I think that's unanimous, Trina, is that correct?
That's correct, Chairman.
Thank you. Okay, in which case we'll now move on to agenda item 11, the work programme. Simon.
Thank you, Chairman. The work programme for the November and December meetings is set out on pages 124 and 125 of the agenda pack. I won't talk about any of those details, but a couple of those items for next time have been mentioned already during the course of the morning. Thank you.
Thank you, Simon. I think there was some mention, and I think it again would be down on the winter plan. We have heard from ULHT today that there wouldn't be a winter plan per se, but I think it would be interesting to see what their plan is moving forward, because there must be some way that they are putting this forwards and the CCG are pushing.
Mr. Chairman, if I may,
Yes,
Simon Evans, the ULHT Simon Evans, not our own fantastic Simon Evans,
yes.
mentioned they've got a plan called Phase 3.
That's correct.
And I'm just wondering if that is in lieu of the winter plan, that perhaps we could see what this Phase 3 plan is. Thank you, Mr. Chairman.
Thank you, Councillor Whittington. Yes, indeed. I would like to see that element as well, but I think we also want to see it in terms of what they're doing wider than just ULHT's trust. So I think it may build into that, but we will get clarification. Thank you. Councillor Wootton.
Thank you, Chairman. Are we able to look at the success or not the success of the Ask My GP scheme, whereby people can send in their ailments to the GP and get a reply back.
Yes, I believe that's what Sarah Jane was alluding to earlier. We did sort of ask that we almost, not clubbed together, that's perhaps the wrong word, but, you know, brought all of that item together around the access of primary care at the moment, in terms of whether it be online, telephone, or in person.
Okay, thank you.
Thank you. Councillor Brewis, did you want to come in?
No. It's just it's already been said. Thank you, Chairman.
Thank you. In which case, I will take it everyone is happy unless there is dissent with the work programme moving forwards. No? Okay. In which case, I'd like to thank you all very much for your attendance today in what has been a little bit of a hiccup meeting, but I think went incredibly well nevertheless. So thank you all very much. Modern technology will. Thank you. Bye.
Take care.